Hello and welcome to your ultimate guide for your NHA CPT exam. My goal today is give you everything that you need to understand the full concepts, master them, and walk you through the NHA CPT exam with total confidence. In this video we will cover federal safety agencies, accreditation standards, ethics and HIPAA, bloodborne pathogens, quality control response. With over 100 plus success stories, we have proven our videos will help you pass your exam on the first attempt. And remember, our website helps you to practice your NHA CPT exam with our practice questions, timed mock exams and study guides. You will find the link in the description below. So let's get started.
Question 1. A processing technician learns about HIPAA privacy rule requirements for fax and email transmission of laboratory results. The rule sets minimum necessary standards and breach notification rules for protected health information transmitted electronically. Which of the following standards matches the HIPAA minimum necessary disclosure rule? Your options are A. Disclose all PHI broadly. B. Share only with insurer. C. Disclose nothing ever. D. Limit disclosure to minimum needed. Which one is it? Pause the video if you need more time. The correct answer is D. Limit disclosure to minimum needed. D is correct because the minimum necessary standard limits disclosure of protected health information to the minimum amount needed for the specific purpose. The rule applies to fax, email, and verbal disclosures during routine laboratory result distribution. A is wrong because disclosing all PHI broadly violates the minimum necessary standard. HIPAA limits disclosure to only what is required for treatment, payment, or operations rather than broad distribution. The standard reflects current practice in routine clinical phlebotomy. B is wrong because sharing only with the insurer ignores other legitimate uses like treatment and care coordination. The standard limits disclosure to minimum needed for the purpose regardless of the specific recipient. C is wrong because disclosing nothing ever blocks legitimate care coordination and treatment communication. The minimum necessary rule limits disclosure to what is required, not to no disclosure at all. The standard reflects current practice in routine clinical phlebotomy. The minimum necessary standard is the HIPAA privacy rule's core limit on how much protected health information moves with any single disclosure. It isn't about who can receive information, it's about how much they receive. Think of a faxed lab result. The cover sheet carries the patient name, record number, and result value. Exactly what the receiving clinic needs. Social security numbers, diagnosis histories, and unrelated chart entries must stay off that sheet entirely. The standard operates in 3 layers. Access control maps workforce roles to information categories. Request handling forces staff to provide only the needed subset. Routine disclosure design shapes work products so they carry only what downstream parties require. Minimum necessary becomes built into the workflow. 4 carve-outs lift the cap entirely. Treatment-to-treatment exchange between active providers is uncapped because clinicians need the full clinical picture. Patients accessing their own records, mandatory legal disclosures, and public health reporting all follow their own separate rules. These are exceptions, not the default. The exam trap is mistaking a carve-out for the default. When no exception applies, the cap holds. Match the size of every disclosure to the size of the request, no more. Question 2. A laboratory accredited by CAP receives mailed unknown specimens 3 times per year for blind analysis. Staff use these results to demonstrate ongoing analytical accuracy under CLIA rules. Which of the following formal programs matches this activity in routine clinical practice in routine clinical phlebotomy practice? Your options are A. Westguard rules. B. Sentinel event review. C. Proficiency testing. D. Tracer methodology. Take a second. Which answer would you pick? The correct answer is C. Proficiency testing. C is correct because proficiency testing programs send blinded specimens at regular intervals so the laboratory can compare its values against peer results. CAP runs the largest such program globally, and CLIA mandates participation for non-waived analytes. A is wrong because Westgard rules are statistical control rules applied to internal quality control runs using Levy-Jennings charts. They monitor daily analyzer performance with control material rather than blinded external specimens shipped to the laboratory. B is wrong because Sentinel Event Review investigates rare patient harm events such as wrong site surgery or transfusion incompatibility. It does not involve mailed unknown specimens, since Sentinel Review focuses on root cause analysis after a serious safety failure. D is wrong because tracer methodology is the inspection technique Joint Commission surveyors use to follow a patient's care path through several departments. Tracer activity is conducted by surveyors on site, not through periodic mailed specimens for analysis. Proficiency testing is the external process that validates whether a laboratory's analytical results can actually be trusted by clinicians. It works by sending blinded, unknown specimens from an outside provider for the lab to analyze under routine conditions. Blinded vials arrive from the provider. The lab runs them like any patient sample, and the results are graded against a peer group consensus built from hundreds of other laboratories. That external verdict is what separates proficiency testing from anything the lab can verify on its own. Internal quality control is necessary but not sufficient. When the same instrument, operators, and control lot are used every day, they can all drift together in ways no internal check will catch. Only an outside specimen graded against a peer consensus can expose that kind of systematic error. 3 programs dominate the marketplace: the College of American Pathologists, the American Association of Bioanalysts, and the American Proficiency Institute. All are regulated under CLIA, which requires every non-wave test to be enrolled in an approved program. The acceptance threshold sits at 80% for most analytes. A lab that falls below that on the same analyte in 2 of 3 consecutive testing events is judged unsuccessful, faces corrective action, and may lose certification for that test. Question 3. A phlebotomy technician evaluates a prospective whole blood donor at a community blood drive. She reviews the basic AABB eligibility criteria including weight, hemoglobin, blood pressure, pulse, and temperature. Which of the following weights matches the AABB minimum for routine adult whole blood donation? Your options are 110 pounds, B 90 pounds, C 80 pounds, D 150 pounds. Before I reveal it, which one do you think is right? The correct answer is A, 110 pounds. A is correct because the AABB minimum weight for routine whole blood donation is 110 pounds. Smaller donors risk hypertension and adverse reactions because the standard 450 milliliter draw represents a larger fraction of total blood volume. B is wrong because 90 pounds is below the AABB minimum and would represent more than 13% of total blood volume in a 450 milliliter donation. The minimum is set higher to protect the donor. C is wrong because 80 pounds is far below the AABB minimum and would risk severe hypertension during donation. The minimum at 110 pounds protects the donor from fluid shift reactions. D is wrong because 150 pounds exceeds the AABB minimum and would unnecessarily disqualify many eligible donors. The minimum at 110 pounds is well below this and supports the donor pool. The AAB sets a minimum body weight of £110 for routine whole blood donation. This isn't an arbitrary cutoff. It's grounded in the physiology of how much blood a donor can safely give. A donor's circulating volume is roughly 70 milliliters per kilogram of body weight. At £110, a 450 milliliter draw removes about 13% of total blood volume, within a safe range. Drop to £90 and that same draw climbs above 15%, sharply raising the risk of vasovagal reactions, hypertension, and syncope. Weight is only the first layer of screening. After the scale, the donor receives a hemoglobin check, a temperature reading, a blood pressure and pulse measurement, and a risk-based questionnaire. A donor who clears every threshold moves to the chair. Failing any single criterion results in deferral. Exam writers offer near-miss values to test whether you've memorized the exact rule. 80 and 90 pounds feel plausible but fail the volume math. 150 pounds would unfairly exclude many healthy small adults. The answer is always 110 pounds, the precise AABB minimum. The 110-pound rule is a calculated guardrail against hemodynamic instability, not a judgment on donor quality. Keep the fraction of total volume logic in mind, and the number will never slip away on exam day. Question 4. A processing technician is confirming the laboratory's centrifuge maintenance routines, including monthly verification of rotor speed using an external instrument. CLSI specifies a tolerance for displayed versus measured speed. Which of the following tolerance percentages matches the CLSI standard for centrifuge RPM verification? Your options are A plus or minus 1%, B plus or minus 20%, C plus or minus 5%, D plus or minus 50%. What's your answer? Commit to one before I continue. The correct answer is C, plus or minus 5%. C is correct because the CLSI standard requires centrifuge RPM verification to be within plus or minus 5% of the displayed value. Monthly verification with an external tachometer documents this tolerance for the maintenance log. A is wrong because plus or minus 1% is tighter than the CLSI standard requires. The actual tolerance sits at 5%, which is achievable across most commercial laboratory centrifuges and routine maintenance. B is wrong because plus or minus 20% is far too loose and would allow significant analytical variation. The CLSI standard tightens this tolerance to 5% for reliable separation across runs over time. D is wrong because plus or minus 50% is so loose that the centrifuge would essentially be uncalibrated. The standard sets 5% as a tolerance to ensure consistent force across runs. The Clinical and Laboratory Standards Institute sets a specific tolerance for centrifuge speed verification. Understanding why this number exists requires looking at the physics connecting rotor speed to the force actually applied to a sample tube. Relative centrifugal force scales with the square of angular velocity. That squaring relationship means a 10% drift in RPM produces roughly a 21% error in actual force at the rotor edge. The 5% tolerance was chosen as the balance point, strict enough to protect analytical results, yet achievable with normal motor and sensor variation on commercial equipment. Verification is straightforward. A photoelectric or magnetic tachometer senses rotor rotation once the centrifuge stabilizes at its representative daily speed. The technician compares the display value to the tachometer reading. If they agree within 5%, the maintenance log records a passing result with the date, technician initials, and both numbers. If not, the centrifuge is taken out of service immediately. The exam tests whether you can distinguish the correct tolerance from plausible sounding alternatives. Plus or minus 1% feels rigorous but exceeds what commercial centrifuges reliably achieve. Plus or minus 20% allows analytical drift into routine results. Plus or minus 50% describes a malfunctioning instrument. 5% is the only correct answer because it is the explicit CLSI standard derived from real analytical performance needs. Remember, centrifuge speed verification is performed monthly using an external tachometer, and the CLSI acceptable tolerance between displayed and measured RPM is plus or minus 5%. This single number controls the accuracy of every relative centrifugal force applied during routine specimen processing. Question 5. A phlebotomy technician is filling out labels on 4 blood culture bottles after collecting 2 sets from 2 different anti-cubital sites in quick succession. Labels must carry the specific information that the laboratory needs to interpret paired positives correctly. Which of the following information elements is critical? Your options are A. Source site for each set, B. Patient social security number, C. Antibiotic dose history, D. Phlebotomist home address. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. Source site for each set. A is correct because the source site is critical, so the microbiologist can pair positives across 2 sets. Labels should read source plus set number, such as write anti-cubital set 1 and left, anti-cubital set 2 clearly. B is wrong because the patient's social security number is not required on the bottle label and could create privacy exposure if visible. Identifiers are typically name and medical record number on the printed label. C is wrong because antibiotic dose history is recorded on the requisition rather than the bottle label. Bottles need patient identifiers, time, source, and phlebotomist initials, but not antibiotic specifics on the label. D is wrong because the phlebotomist home address has no place on a bottle label. Phlebotomist initials or identification number suffice for traceability without revealing personal contact information. The standard reflects current practice in routine clinical phlebotomy. Blood culture labeling isn't just bureaucracy, it's the foundation of diagnostic reasoning at the microbiology bench. The information on each bottle determines whether a positive result means true infection or contamination. Every bottle must carry the patient identifier, the date and time of collection with the phlebotomist's ID, and critically, the source site and set number. For example, write anticubital set 1 aerobic. The standard protocol is 2 sets drawn from 2 separate venipuncture sites. 4 bottles total, each pair traceable back to its own arm, each disinfected independently before the draw. When the same organism grows from both sets at 2 separate sites, that pattern is extremely difficult to explain by contamination alone and is reported as true bacteremia, a single set positive, especially with a skin commensal like coagulus negative stuff, is read as probable contamination. Source, site, and set number belong on the bottle because the bench cannot interpret results without them. Social security numbers violate HIPAA, and antibiotic history belongs on the requisition, not the label. Only information essential to microbiologic interpretation goes on the bottle itself. Question 6. A phlebotomy technician is learning the purpose of centrifugation in routine specimen processing. The supervisor explains that centrifugal force separates components by density, and a thixotropic gel layer plays a specific physical role in serum separator tubes during the spin. Which of the following best describes that role? Your options are A. Activates clot formation faster, B. Sedimentate platelets only, C. Form a barrier between cells and serum, D. Concentrate microorganisms. Which would you go with? Lock it in before the reveal. The correct answer is C. Form a barrier between cells and serum. C is correct because the thixotropic gel migrates between cells and serum during centrifugation, hardening into a stable barrier within minutes. The barrier prevents cells from remixing with serum during transport and downstream handling. A is wrong because clot formation is accomplished by silica or other clot activators, not by the thixotropic gel. The gel is purely a physical separator that flows during the spin and hardens afterward. B is wrong because platelet sedimentation is a separate centrifugation effect rather than the role of gel. The gel exists to keep cellular elements physically separated from serum, not to sediment platelets specifically. D is wrong because concentration of microorganisms is not the role of separator gel in routine chemistry tubes. Cultures use entirely different broth-based bottles, not gel separator tubes for microbial growth detection. Serum separator tubes contain a thixotropic gel that plays a purely mechanical role, no chemistry involved. Understanding how it behaves under centrifugation explains why it's so useful in clinical workflows. During the spin, centrifugal shear temporarily lowers the gel's viscosity, allowing it to flow and settle at the density boundary between the heavier cell layer and the lighter serum above. When the rotor stops, viscosity recovers and the gel hardens into a stable plug. That's the definition of thixotropic behavior. Thixotropic means viscosity drops under shear and recovers at rest. The gel flows during the spin, settles at the interface, and then locks in place. A purely physical mechanism that keeps cells sealed below and serum accessible above. It's important to separate the gel's role from the silica clot activator coating the tube wall. The clot activator catalyzes fibrin formation so the clot completes quickly. The gel does not activate clotting, it only separates and seals. When an exam stem describes a substance that flows during spinning and hardens afterward, it's pointing to the thixotropic gel and its barrier role. When clotting activation is the subject, the answer is the silica particles, same tube, completely different function. Question 7. A phlebotomy technician preparing a urine collection plan must instruct a patient on a 24-hour collection started at 0700 Monday. The patient is unsure which voids count toward the test. Which sequence matches the correct 24-hour urine collection technique for this patient at home? Your options are A. Collect everything from 7 a.m. B. Random samples 4 times daily. C. Refrigerate only the last container. D. Discard first void, collect through next morning. Don't overthink it. Which one feels right? The correct answer is D. Discard first void, collect through next morning. D is correct because the patient discards the start time void and collects every subsequent void into the container with appropriate preservative, including the next morning's first void at the same clock time. This captures exactly 24 hours of urine output. A is wrong because collecting everything starting at the 7 a.m. Monday void includes a void with urine produced before the start time. The collection would overestimate output for that day, since some of the urine accumulated before the official start. B is wrong because collecting random samples 4 times daily does not match the 24-hour technique and would not capture the full output. Random sampling answers a different clinical question and does not support analyte excretion calculations like creatinine clearance. C is wrong because collecting for 24 hours but refrigerating only the last container ignores stability requirements for the rest of the specimen. Most collections need refrigeration throughout, so partial refrigeration would degrade analytes during the collection period. The 24-hour urine collection exists because a single random sample can only tell you concentration, not how much of a substance the kidneys handled across an entire day. To measure total daily excretion, you need every drop of urine produced in exactly 24 hours. The math is straightforward. Urinary excretion equals concentration multiplied by total volume. Tests like creatinine clearance, 24-hour protein, and catecholamines all require knowing that total daily amount, something no single spot sample can provide. The technique begins counterintuitively. At the start time, the patient discards the first void because that urine accumulated before the clock started. Every void after that goes into the refrigerated container, including the final void at the same clock time the next morning. Students often invert the rule and start collecting immediately, but that captures urine made before the window opened. Discard first, then collect through the same clock time next day. Refrigeration applies to the whole collection, not just the lost void added. Only the time 24-hour collection answers questions about total daily excretion. Random urine suits routine urinalysis. First morning specimens are used for pregnancy or microalbumin screening, and postprandial specimens check glucose. Knowing which test requires which collection type is the core exam skill here. Question 8. A nurse asks the technician what NPO actually means for a pre-anesthesia patient awaiting surgery early tomorrow morning. The technician explains the precise scope of the order so the nurse can counsel the patient and confirm with the operating team. Which definition matches the NPO order most precisely? Your options are only water permitted, B, only routine medications permitted, C, nothing by mouth including water and meds, D, coffee and water permitted. Got a guess? Lock it in. The correct answer is C, nothing by mouth including water and meds. C is correct because NPO means nothing by mouth, including water and oral medications, unless specifically authorized by the surgical or anesthesia team. The order targets aspiration risk during general anesthesia, so even small intake can postpone the procedure. A is wrong because permitting only water still violates strict NPO and may delay surgery. Some protocols allow sips of water with critical medications up to a defined cutoff, but the default NPO interpretation is no water at all without specific authorization. B is wrong because permitting routine medications without explicit authorization undermines anesthesia safety. Some medications must be held. Others may be given with a sip of water under supervised protocols. But blanket permission is not what NPO means clinically. D is wrong because permitting coffee and water explicitly contradicts the NPO order. Coffee carries far more aspiration and metabolic risk than water, and including it in the permitted list would compromise the anesthesia plan from start to finish. NPO, from the Latin nil per os, means nothing by mouth, and it exists for one specific reason, protecting the airway when general anesthesia removes the body's normal defenses. Under general anesthesia, protective reflexes are lost. If the stomach holds material at induction or extubation, contents can travel up the esophagus, into the trachea, and reach the lungs, causing chemical pneumonitis, acute respiratory distress syndrome, or death. NPO prohibits solid food, all liquids, oral medications, and anything else by mouth. Exceptions, like a critical medication with a small sip of water, must be explicitly authorized in writing by the surgical or anesthesia team. A common trap is confusing NPO with the fasting order for glucose or lipid panels. Lab fasting is a looser standard tied to analyte stability. Baxol folks on. Water and routine medications are typically permitted. NPO is stricter and tied to airway safety. They are not interchangeable. When a patient asks whether they may drink or take a medication before surgery, the phlebotomist's job is not to guess. Convey the question to the surgical or anesthesia team, who hold the authority to grant or deny any exception to NPO. Question 9. A patient under droplet precautions for influenza requires a phlebotomy draw. Droplet pathogens travel in larger respiratory droplets, typically less than 6 feet. Which of the following respiratory protections matches CDC droplet precaution requirements for staff entering this room in routine clinical practice? Your options are A. An 95 respirator only, B. A cloth covering only, C. A chemical splash visor alone, D. A standard surgical mask. Which one is it? Pause the video if you need more time. The correct answer is D. A standard surgical mask. D is correct because a standard surgical mask satisfies droplet precaution requirements for influenza, pertussis, and similar pathogens. The mask blocks larger respiratory droplets that fall to surfaces within a few feet, which is the dominant transmission route for these agents. A is wrong because an N95 respirator is reserved for airborne precautions involving droplet nuclei smaller than 5 micrometers. Using N95 routinely for droplet pathogens overconsumes scarce respirator supply without adding benefit beyond what a surgical mask already provides reliably. B is wrong because a cloth covering offers no certified filtration claim and is not approved for droplet precautions. Healthcare encounters require regulated face protection, and cloth coverings lack the minimum filtration performance required for occupational respiratory droplet protection in clinics. C is wrong because a splash visor protects against fluid splatter to the face but does not filter inhaled droplets. Visors complement masks rather than replacing them, and using a visor alone leaves the airway unprotected during droplet exposure encounters with patients. Droplet precautions apply when a pathogen travels inside large respiratory particles, those greater than 5 micrometers in diameter, that fall within roughly 6 feet of the source. Understanding the physics behind droplet transmission explains why each element of the protocol exists. Common droplet precaution pathogens include influenza, pertussis, mumps, meningococcal disease, and streptococcal respiratory illness. These all share the same physics. Their particles are heavy enough to follow a ballistic arc and settle within a few feet rather than drifting through the air. Because larger droplets lose momentum quickly and obey gravity, they settle onto surfaces and masks rather than floating freely. A standard surgical mask intercepts the short-range trajectory, blocking droplets before they reach the wearer's airway and also capturing particles the worker produces, protecting the patient in return. The critical exam distinction is droplet versus airborne precautions. Airborne pathogens, tuberculosis, varicella, and measles, travel as aerosols smaller than 5 micrometers that can drift across a room. Those require a fit-tested N95 respirator and a negative pressure room, not a surgical mask. When you see influenza or pertussis, reach for a surgical mask plus eye protection if splash is possible. When the pathogen switches to tuberculosis or measles, the answer changes to an N95. Matching the right protection to the right transmission route is the core skill here. Question 10. A phlebotomy technician is preparing a butterfly wing set with a 23 gauge needle for a hand vein draw. Which of the following lengths matches the standard butterfly device in routine clinical practice at the bedside in routine clinical phlebotomy practice? Your options are A. 1.5 inch, B. 3/4 inch, C. 2 inches, D. 1 inch. Take a second. Which answer would you pick? The correct answer is B. 3/4 inch. B is correct because the standard butterfly needle is 3/4 inch, designed for shallow surface veins like those on the dorsal hand or wrist. The shorter needle matches the 10 to 15 degree insertion angle. I is wrong because 1.5 inch is the deeper straight needle length for adults with significant subcutaneous tissue. The butterfly is designed for shallow surface access, so this length does not match. C is wrong because 2 inches exceeds normal butterfly needle length and is not part of standard butterfly product lines. The butterfly is engineered for surface vein access with a short steel cannula instead. D is wrong because 1 inch is the standard length for adult straight, multi-sample needles in routine antecubital venipuncture. The butterfly uses a shorter cannula because its target veins sit closer to skin. The butterfly winged infusion set is built specifically for shallow, difficult-to-access veins. Understanding why its dimensions and design exist will help you apply this knowledge confidently on the exam. The device has 4 key parts: the short 3/4 inch needle, the plastic wings for grips, the flexible luer tubing that absorbs patient movement, and the luer adapter that connects to a tube holder for sample collection. Dorsal hand veins sit very close to the skin surface and require a low insertion angle of around 10 degrees. A 1 inch needle entering at that angle would overshoot the vein entirely, so the 3/4 inch length is specifically matched to the shallow depth. Needle length always matches vein depth. The 3/4 inch butterfly is for shallow veins. The 1 inch straight needle is standard for adult antecubital draws, and the 1.5 inch is reserved for deeper veins. The 2 inch needle is never part of any butterfly product line. When you see a stem describing wings, flexible tubing, a hand or wrist draw, or fragile rolling veins, the butterfly with a 3/4 inch needle is the correct answer. Length always matches depth. Question 11. A phlebotomy technician applies a tourniquet and palpates a vein for nearly 3 minutes while looking for a viable target. Which of the following adverse effects does prolonged tourniquet time most directly produce in routine clinical practice today, in routine clinical phlebotomy practice? Your options are A. Reduced specimen volume, B. Hemolysis only, C. Hemoconcentration with elevated analytes, D. Lowered hematocrit. Before I reveal it, which one do you think is right? The correct answer is C. Hemoconcentration with elevated analytes. C is correct because prolonged tourniquet time produces hemoconcentration as fluid leaves the vascular space. Cells, large proteins, and protein-bound analytes increase artifactually, including hematocrit, albumin, calcium, and many enzymes. The standard reflects current practice in routine clinical phlebotomy. Us is wrong because reduced specimen volume is not the dominant effect of prolonged tourniquet application. Volume depends on tube vacuum and flow, while hemoconcentration changes relative concentration. The standard reflects current practice in routine clinical phlebotomy. B is wrong because hemolysis can occur during difficult draws but is not the direct effect of tourniquet time itself. Hemoconcentration is the recognized analyte affecting consequence of prolonged occlusion. The standard reflects current practice in routine clinical phlebotomy. D is wrong because lowered hematocrit is the opposite of the actual effect, since hemoconcentration raises hematocrit. Fluid loss from the vascular space concentrates cells, raising the measured hematocrit. The standard reflects current practice in routine clinical phlebotomy. When a tourniquet stays in place too long during venipuncture, a phenomenon called hemoconcentration occurs. Understanding why requires looking at the forces that govern fluid movement across capillary walls. Normally, capillary hydrostatic pressure and oncotic pressure are balanced. A tourniquet raises venous pressure upstream, increasing hydrostatic pressure across the capillary bed. Plasma water is pushed into the interstitium, but red cells and large proteins are too big to follow, so they become concentrated in the remaining blood. The concentrated blood produces measurable elevations across several analyte classes: hematocrit, total protein, albumin, calcium, and many enzymes all rise, not because the patient's physiology changed, but because the local draw site no longer reflects systemic blood. It is important to distinguish hemoconcentration from other pre-analytical errors. Hemolysis comes from turbulent flow and causes cell lysis, not concentration shifts. Reduced specimen volume reflects mechanical problems. And a lowered hematocrit is the opposite of what prolonged occlusion produces, a common distractor on exams. The practical correction is straightforward. Release the tourniquet. Allow 2 minutes for venous equilibration. Then reapply for under 60 seconds before puncture. Results drawn this way reflect true systemic values rather than an artifact of occlusion. Question 12. A patient who speaks only Mandarin arrives for a routine blood draw with her bilingual adult son. The technician needs language support for consent and pre-draw screening before any tube is opened. Which approach matches federal expectations and current best practice for clinical communication during this encounter? Your options are: A. Use a certified medical interpreter. B. Use the son as interpreter. C. Draw silently and document barrier. D. Defer the draw indefinitely. What's your answer? Commit to one before I continue. The correct answer is A. Use a certified medical interpreter. A is correct because Title 6 and ACA Section 5057 require facilities receiving federal funds to provide certified interpreters at no cost. Family interpreters can soften, omit, or filter information, which compromises clinical accuracy and patient safety during the encounter. B is wrong because using the bilingual son risks filtered or softened messages, especially around sensitive topics. Family interpreters lack training in clinical terminology and confidentiality expectations, so the federal standard requires certified interpreter services for clinical encounters. C is wrong because drawing silently bypasses consent and safety screening and creates documented liability for the facility. The standard requires meaningful communication, since procedures without consent qualify as battery in any U.S. jurisdiction. D is wrong because deferring the draw indefinitely abandons the patient's care and ignores available resources. Hospitals contract telephone or video relay interpreter services that join within minutes, so deferral fails both the patient and the facility. When a patient has limited English proficiency, federal law guarantees them a certified medical interpreter. Wa-ati-ait, a neutral, trained professional who conveys clinical communication fully and accurately between two languages. This is not a courtesy, it is a civil right. The legal foundation rests on two statutes. Title 6 of the Civil Rights Act prohibits national origin discrimination in federally funded programs, and courts read language access as part of that protection. Section 1557 of the Affordable Care Act extends the same rule to virtually every facility accepting Medicare or Medicaid, and the cost falls on the facility, never the patient. In practice, the interpreter joins by phone, video, or in person, introduces themselves, confirms language and dialect, and conveys each speaker's words in first person. A family member present in the room may offer support, but should not serve as the interpreter. The critical exam distinction is between a certified interpreter and a family or friend interpreter. Family members soften, omit, or substitute messages, especially around sensitive topics like mental health or end-of-life decisions. They lack training in clinical terminology and carry personal bias that distorts their rendering. When a STEM shows a patient with a bilingual relative offering to translate, the standard answer is to bring in a certified interpreter. Language access is a federal civil right, and certification, not bilingual ability alone, is what the standard requires. Question 13. The test uses a specific chemical and a low voltage electrical current to stimulate localized sweat production for collection. Which of the following technique names matches the sweat chloride induction method in routine clinical phlebotomy practice for the routine adult outpatient draw. Your options are A. Tandem mass spectrometry, B. Pilocarpine iontophoresis, C. Filter paper Guthrie collection, D. Capillary blood gas analysis. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Pilocarpine iontophoresis. B is correct because pilocarpine iontophoresis uses a low voltage current to drive pilocarpine into the skin, stimulating localized sweat for collection. The collected sweat is analyzed for chloride concentration to evaluate cystic fibrosis. A is wrong because tandem mass spectrometry analyzes amino acids, acyl carnitines, and other metabolites in dried blood spots for newborn screening. It is not the technique used to induce sweat for chloride analysis at all. C is wrong because the filter paper Guthrie collection is used for newborn screening with dried blood spots. It does not involve sweat induction or chloride analysis, so it does not match the cystic fibrosis sweat workup. D is wrong because capillary blood gas analysis measures pH and gas tensions from a heel stick specimen. It is unrelated to sweat chloride testing for cystic fibrosis evaluation in pediatric patients. Pilocarpine iontophoresis is the gold standard for diagnosing cystic fibrosis, and understanding why requires a look at the underlying channel physiology and how the test actually works at the bedside. In a healthy sweat duct, the CFTR chloride channel on the apical membrane reabsorbs chloride from the duct lumen before sweat reaches the skin. In cystic fibrosis, CFTR mutations disable this channel, so chloride stays in the lumen and sweat chloride concentration rises well above normal. The test runs in 3 stages. First, a pilocarpine-soaked electrode is placed on the volar forearm, and a low-voltage direct current drives the positively charged pilocarpine ions into the local sweat glands over about 5 minutes. Then the electrodes are removed and a collection device captures sweat for 30 minutes before analysis. Interpreting the result depends on the chloride concentration. Values above 60 millimoles per liter on 2 occasions support a CF diagnosis. Values between 30 and 59 require further evaluation, often genetic testing. Values below 30 are normal, and if the collected volume is inadequate, the test must be repeated rather than interpreted from insufficient material. Pilocarpine iontophoresis is powerful because it probes CFTR channel function directly, without genetic sequencing, yielding a reproducible number that clinicians can compare against established thresholds to confirm or rule out cystic fibrosis. Question 14. A patient reports a strong vasovagal history, including loss of consciousness during her last venipuncture. The technician is planning the encounter to reduce the risk of repeat syncope while still completing the draw safely and efficiently. Which combination of strategies best matches CLSR and clinical guidance for this patient? Your options are A. Standard chair, distract with chatter, B. Standing position, fast technique, C. Supine distraction, concealed needle, D. Show needle to demystify procedure. Which would you go with? Lock it in before the reveal. The correct answer is C. Supine distraction, concealed needle. C is correct because the supine position protects against fall during syncope, and distraction plus a concealed needle reduces the visual triggers that drive vasovagal responses. The phlebotomist also watches for early signs throughout the draw to intervene quickly if needed. A is wrong because the standard chair is acceptable for low-risk patients but not for documented vasovagal history with prior loss of consciousness. The supine position is the safer choice since loss of consciousness in a chair still risks falls. B is wrong because the standing position is forbidden for any patient because of fall risk. and fast technique alone does not address the vasovagal response itself. Standing patients who faint typically fall forward, sometimes onto the inserted needle directly. D is wrong because showing the needle increases vasovagal trigger exposure, which is the opposite of what this patient needs. The phlebotomist conceals the needle and minimizes visual cues during the draw to reduce the chance of repeat syncope events. When a patient has a documented history of fainting during venipuncture, the standard chair and routine technique are not enough. The correct approach combines 3 specific elements that together address both the trigger and the fall risk. The vasovagal response is a reflex driven by the vagus nerve. It simultaneously slows heart rate and dilates peripheral vessels, causing cardiac output and blood pressure to fall. Cerebral perfusion drops rapidly, and the patient can lose consciousness within seconds. The protective strategy has 3 elements: positioning the patient supine on a reclining draw bed to eliminate fall risk, using light conversation as distraction to reduce emotional triggers, and concealing the needle and equipment to prevent visual triggers that activate the autonomic cascade. Several intuitive approaches are incorrect. The standard chair leaves fall risk unaddressed for high-risk patients. Standing is forbidden for any phlebotomy patient. Showing the needle to reduce anxiety actually worsens vasovagal triggers. Distraction alone, without the supine position, does not protect against a syncopal fall. For any patient with documented vasovagal syncope history, only the full combination, supine positioning, concealed needle, and active distraction, addresses both the physiological trigger and the physical danger of a fall. Question 15. A phlebotomy technician is reviewing a chemical exposure record that lists a NIOSH-REL and an OSHA-PEL with different numerical limits for the same agent. The supervisor asks which value the laboratory must legally treat as enforceable. Which of the following values is enforceable? Your options are A. The NIOSH-REL, B. The OSHA-PEL, C. Either freely chosen, D. Whichever is higher. Don't overthink it. Which one feels right? The correct answer is B. The OSHA-PEL. B is correct because only the OSHA-PEL carries the force of federal law. NIOSH publishes RELs as recommendations based on health research, but they are not enforceable. The laboratory must comply with the OSHA-PEL. A is wrong because the NIOSH REDAM reflects research-derived recommendations and is often more conservative than OSHA limits. However, RELs carry no enforcement weight and cannot be cited against an employer during an inspection or workplace audit. C is wrong because an employer cannot freely choose which exposure limit to follow when federal enforcement applies. The PEL is the legally binding ceiling, regardless of internal preference, and choosing the looser figure would violate OSHA standards. D is wrong because selecting whichever number is higher would expose workers to greater concentrations than law allows. The enforceable PEL controls regardless of comparison, and a higher REL must never override the legally binding lower threshold. When you see 2 exposure limits listed for the same chemical, it's because 2 different agencies publish them for 2 very different purposes. Understanding the difference is essential for anyone working in a laboratory setting. OSHA sits inside the Department of Labor with rulemaking and enforcement authority, publishing permissible exposure limits that carry the force of federal regulation. NIOSH sits inside Health and Human Services with research authority only, publishing recommended exposure limits based on the latest toxicology data, but with no power to enforce them. In practice, a laboratory's chemical hygiene plan must comply with the OSHA-PEL as a hard legal ceiling. A good safety program also uses the more conservative NIOSH-REL as an operational target for engineering controls and ventilation, treating the PEL as the floor and the REL as the goal. This distinction is the exam's sharpest edge. The NIOSH-REL carries no legal force whatsoever, no citations, no fines. Meeting the lower REL does not relieve an employer of the obligation to document compliance with the OSHA PL. The PL is the legal anchor, full stop. Whenever a question gives you two exposure limits and asks which is legally binding, the answer is always the OSHA PL. The NIOSH-REL is valuable guidance, but only one of these carries the weight of federal law. Question 16. A patient on warfarin therapy presents for a routine venipuncture for monitoring labs. The technician knows anticoagulants prolong bleeding from puncture sites and applies extra care after needle removal. Which post-draw step best matches the recommended approach for an anticoagulated patient like this one in standard practice? Your options are: A. Apply ice to the site. B. Use butterfly needle, no pressure. C. Firm pressure 5 minutes, verify hemostasis. D. Refuse the draw entirely. Got a guess? Lock it in. The correct answer is C. Firm pressure 5 minutes, verify hemostasis. C is correct because anticoagulated patients need firm direct pressure for at least 5 minutes after needle removal, with verified hemostasis before bandaging. The phlebotomist should also recheck the site on rounds or before discharge to catch delayed bleeding events. A is wrong because applying ice to the site is not the standard intervention for anticoagulant-related bleeding. Direct pressure is the proven approach, and ice does not address the prolonged clotting cascade driving extended bleeding risk in these patients. B is wrong because using only a butterfly needle does not address the hemostasis question. Needle gauge affects collection comfort and hemolysis risk, but bleeding control depends on pressure and time rather than the device used to draw blood. D is wrong because refusing the draw because of bleeding risk abandons the patient and the clinical order. Anticoagulated patients are routinely drawn with appropriate pressure and observation, since refusing would deprive their care team of needed information. When a patient is on anticoagulant therapy, normal post-draw pressure simply isn't enough. The clotting cascade or platelet function is intentionally impaired, which means the puncture site needs more time and more vigilance to seal properly. After a needle exits a vein, 3 processes work together to stop bleeding. First, vasoconstriction reduces local flow. Second, a platelet plug forms within seconds. Third, the coagulation cascade weaves a fibrin mesh through the plug over the next several minutes, locking the seal. Warfarin, heparin, direct oral anticoagulants, and antiplatelet drugs each disrupt a different part of that sequence. The result is that the standard 1 to 2 minute pressure used for unmedicated patients leaves the puncture site at serious risk of hematoma or delayed bleeding. The technique is straightforward but demands patience. Folded gauze is placed directly over the puncture site and held with firm 2-finger pressure. The patient keeps the arm straight, not bent, while the phlebotomist times a full 5 minutes by clock. Only after lifting the gauze and confirming the site is fully clotted should a bandage be applied. Ice and butterfly needles do not address hemostasis time. For any anticoagulated patient, firm direct pressure for at least 5 minutes with a hemostasis check is the standard, and what the exam tests. Question 17. A phlebotomy technician is reviewing tube colors and additives for an order set that includes a complete blood count and a hemoglobin A1C. She wants the tube and additive that supports both tests using the same EDTA whole blood specimen. Which of the following combinations matches? Your options are A. Lavender with potassium EDTA, B. Light blue with sodium citrate, C. Grey with sodium fluoride, D. Red with clot activator. Which one is it? Pause the video if you need more time. The correct answer is A. lavender with potassium EDTA. A is correct because the lavender tube contains potassium EDTA, which preserves whole blood for both complete blood counts and hemoglobin A1C. Calcium chelation prevents clotting while keeping cell morphology intact. B is wrong because the light blue tube uses sodium citrate for coagulation testing rather than for hematology. Citrate is reversible and not engineered for cell preservation needed by CBC analyzers. The standard reflects current practice in routine clinical phlebotomy. C is wrong because the grey tube uses sodium fluoride and potassium oxalate to preserve glucose. It does not support hematology assays, since glycolysis inhibition is unrelated to cell counts. The standard reflects current practice in routine clinical phlebotomy. D is wrong because the red tube has a clot activator and produces serum rather than whole blood. Hematology requires anticoagulated whole blood, so a clot activator tube does not support CBC testing. The lavender top tube is the standard collection device for hematology testing. Its additive, potassium ether, is what makes it uniquely suited for complete blood counts, differentials, and hemoglobin A1C assays. Ether works by collating calcium ions, grabbing and sequestering them so the coagulation cascade cannot proceed. Because this happens without adding extra volume, cell counts stay accurate and cell morphology remains intact for several hours at room temperature. Other anticoagulants fall short for hematology. Heparin distorts cell morphology and stains poorly. Sodium citrate dilutes the specimen at a fixed 9:1 ratio, altering cell counts. Sodium fluoride blocks glycolysis but does not preserve cells. Only EDTA keeps cells morphologically clean without changing specimen volume. A single lavender top tube supports both hematology and chemistry workflows. Intact cells are counted and characterized on the hematology analyzer, while the same whole blood is listed for the hemoglobin A1C assay, measuring the glycated fraction by chromatography or immunoassay. When an exam stem describes a tube supporting both hematology and glycated hemoglobin testing, the answer is always the lavender top with EDTA. Any other tube color paired with a complete blood count is wrong. Question 18. A phlebotomy technician is collecting a semen analysis specimen and reviews the patient instructions before collection. The technician recalls the abstinence interval, the container type, and the transport temperature requirements specific to semen analysis. Which of the following combinations matches the standard for routine semen analysis? Your options are A. No abstinence required. B. Hours of cold storage. C. 2 to 7 days abstinence, body temperature. D. 1 year abstinence required. Take a second. Which answer would you pick? The correct answer is C. 2 to 7 days abstinence, body temperature. C is correct because the standard specifies 2 to 7 days of sexual abstinence, collection into a sterile non-spermicidal container, and body temperature transport to the lab within an hour. The abstinence and temperature both preserve sperm viability. A is wrong because no abstinence yields a non-standard specimen and skews semen analysis results. The standard insists on 2 to 7 days of abstinence, with 3 days being the typical target for routine analysis. B is wrong because cold storage of a semen specimen kills sperm and invalidates motility analysis. The standard requires body temperature transport rather than refrigeration during the journey to the laboratory. The standard reflects current practice in routine clinical phlebotomy. D is wrong because 1 year abstinence is far longer than the standard window and produces non-physiologic specimens. The standard interval is 2 to 7 days for routine semen analysis testing. Semen analysis has strict pre-collection and transport requirements because the 3 parameters being measured, exactly, motility, count, and morphology, are all highly sensitive to timing and environment. The 4 required conditions are a 2 to 7 day abstinence window, a sterile non-spermicidal container, body temperature transport carried against the skin, and delivery to the laboratory within 1 hour. The epididymal storage cycle explains the window. Less than 2 days means the reservoir hasn't refilled, giving low count and volume. More than 7 days means older sperm with reduced motility and more morphologic abnormalities. 2 to 7 days captures the physiologic sweet spot. At the laboratory, the technologist first observes liquefaction over roughly 30 minutes, then performs the analysis on a heated microscope stage. Reporting count, total motility, progressive motility, and morphology against World Health Organization reference ranges. Any deviation from the standard makes the specimen unacceptable. No abstinence skews count and motility. Cold storage or refrigeration destroys motility entirely. Lubricants may be spermicidal, and abstinence beyond 7 days produces non-physiologic results. All 4 are grounds for rejection. Question 19. A clinical instructor reviews 2 needle types in routine adult phlebotomy. She emphasizes that one device has small, flexible plastic grip-in wings, a short steel needle, and a few inches of flexible Luer tubing for control. Which of the following devices matches that description? Your options are A. Straight multi-sample needle, B. Butterfly winged infusion set, C. Multi-sample Luer adapter, D. Blood transfer device. Before I reveal it, which one do you think is right? The correct answer is B. Butterfly winged infusion set. B is correct because the butterfly, also called the winged infusion set, has plastic wings flanking a small steel needle plus a short flexible Luer tubing. The wings allow precise control during shallow insertion. A is wrong because a straight multi-sample needle has a hub that screws into a tube holder and lacks any flexible tubing. The straight design works for routine antecubital draws but has no wings. C is wrong because the multi-sample Luer adapter is a small connector that converts a butterfly Luer end to fit a tube holder. It is an accessory rather than the device with wings. D is wrong because the blood transfer device is a syringe to tube adapter used after a syringe draw. It has no wings or Luer tubing for venous access during the puncture itself. The butterfly winged infusion set, also called the scalp vein set, is a specialized venous access device designed for shallow, difficult veins. Understanding it by its anatomy, not just its name, is the key exam skill. The device has 3 distinguishing parts: a short steel needle, 2 flexible plastic wings that give the operator 2-finger control, and a length of flexible Luer tubing that connects to a tube holder or syringe. A straight multi-sample needle has no flexible interface. Any patient movement transmits directly to the bevel inside the vein. The butterfly solves this. The flexible tubing absorbs motion, the wings give tactile control, and the shorter needle matches shallow targets like the dorsal hand or wrist. 4 devices are commonly confused. The butterfly is the only one defined by wings, a short needle and Luer tubing together. The straight multi-sample needle has a hub and no tubing. The Luer adapter is a small connector bridge, and the blood transfer device moves syringe contents into tubes after the draw is already complete. Whenever an exam stem describes a device with flexible plastic wings, a short steel needle, and flexible Luer tubing, the answer is the butterfly winged infusion set, regardless of whether the name appears in the question. Question 20. A phlebotomy supervisor shows 3 lancet designs and explains which one is now standard of care across clinical settings. The discussion centers on safety mechanism, single-use design, and depth control during capillary collection. Which of the following designs matches the modern standard? Your options are A. Manual fixed blade lancet, B. Reusable adjustable lancet, C. Push-button retractable lancet. D. Plain hypodermic needle. What's your answer? Commit to one before I continue. The correct answer is C. Push-button retractable lancet. C is correct because the push-button retractable lancet is the modern standard. The blade advances to a preset depth and retracts permanently after activation, addressing both depth control and needle stick safety in one device. It's wrong because the manual fixed blade lancet is largely obsolete because the blade does not retract after use. Reusing or accidentally contacting the exposed blade creates needle stick risk that the retractable design eliminates. B is wrong because a reusable adjustable lancet does not exist as a clinical device, since lancets are single-use. Reusable adjustable devices appear only in personal home glucose kits, not clinical practice. D is wrong because a plain hypodermic needle is not a lancet and lacks the depth control mechanism needed for capillary puncture. Using one risks excessive depth and tissue injury rather than a controlled superficial cut. The push-button retractable lancet is the modern clinical standard for capillary puncture, replacing older manual fixed blade designs that left operators exposed to sharps, hazards after use. Understanding why this device exists starts with the 3 problems it was engineered to solve. The device has 3 engineered features. A preset depth delivers a consistent controlled puncture every time. A single-use mechanism prevents accidental reuse. And permanent retraction locks the blade inside the housing after activation, eliminating the sharps hazard for disposal staff and everyone downstream. When the operator presses the button, a compressed spring drives the blade out to the preset depth, makes a controlled cut, and retracts the blade back into the sealed housing, all within milliseconds. The operator never sees an exposed sharp after that moment. Manual fixed blade lancets left the blade exposed after puncture, and needle stick injuries to nurses and phlebotomists were common during disposal. The Needle Stick Safety and Prevention Act of 2000 pushed manufacturers to engineer safer alternatives, and the push-button retractable design became the answer. On the exam, the correct lancet is always the one that checks all 3 boxes: single-use, depth-controlled, and self-sheathing after activation. Any design missing even one of those features, fixed blade, reusable, or a plain hypodermic, falls short of the modern standard. Question 21. A phlebotomy technician is studying yield curves and reads that for adult bacteremia, each additional milliliter of blood drawn into the culture bottles increases pathogen recovery by a specific approximate percentage. Which of the following percentages matches the published increase per additional milliliter? Your options are A. 0.3%, B. 3%, C. 30%, D. 50%. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. 3%. B is correct because each additional milliliter of blood drawn into the culture bottle increases yield by approximately 3% up to about 30 milliliters. The curve plateaus there because organism density in adult bacteremia is typically low. A is wrong because 0.3% is an order of magnitude smaller than the published value. The actual gain per milliliter is closer to 3% across the linear portion of the yield curve. C is wrong because 30% overstates the per milliliter gain by an order of magnitude. The gain is approximately 3% per milliliter, which compounds across the recommended 20 milliliter set total. D is wrong because 50% dramatically overstates the gain. The published curve shows roughly 3% per milliliter, plateauing near 30 milliliters where additional blood adds little additional sensitivity. The standard reflects current practice in routine clinical phlebotomy. Blood culture sensitivity is directly tied to how much blood you draw. Understanding why volume matters so much starts with the biology of bacteremia itself. In true bacteremia, organism density is remarkably low, often fewer than 10 bacteria per milliliter, sometimes less than 1. Drawing more blood simply increases the probability that at least one viable organism ends up in the bottle where it can grow and be detected. Yield rises approximately 3% for every additional milliliter of blood drawn, following a roughly linear relationship up to about 30 milliliters total. Beyond that plateau, extra volume adds little. Below it, organisms are simply missed by sampling error. The broth cannot grow what was never inoculated. The standard adult set is designed to hit that plateau. 2 venipuncture sites, each yielding an aerobic and anaerobic bottle filled with 8 to 10 milliliters. Totals roughly 32 to 40 milliliters across 4 bottles, right at the optimal range identified by the yield curve. Remember incubation time, broth composition, and paired bottles all matter, but volume is the single most studied lever for sensitivity. 3% per milliliter, plateauing near 30, that is the number to know. Question 22. A processing technician learns the laboratory information system delivers test results to the electronic health record using a specific universal interface protocol. The protocol covers admission, order, and result messages between hospital systems. Which of the following protocols matches the standard interface used for laboratory result exchange? Your options are A. DICOM imaging standard, B. FAR genomic profile only, C. Health Level 7 interface protocol, D. ICD-10 diagnosis codes. Which would you go with? Lock it in before the reveal. The correct answer is C. Health Level 7 interface protocol. C is correct because Health Level 7, abbreviated HL7, is the standard interface protocol for laboratory result exchange. The protocol uses message types like ADT for admission, ORM for orders, and ORU for results across hospital systems. Is wrong because DICOM is the imaging standard for radiology rather than laboratory results. The two standards address different clinical data types, with HL7 being the laboratory and clinical data standard. B is wrong because FHIR genomic profile alone is a subset of FHIR specifications rather than the broad laboratory interface standard. HL7 covers the routine laboratory result exchange across hospital information systems. D is wrong because ICD-10 is a diagnosis classification code system rather than an interface protocol. ICD-10 codes appear within HL7 messages, but HL7 is the protocol that carries the messages between systems. Health Level 7 is the universal language that lets hospital information systems talk to each other. It defines exactly how clinical and administrative data moves between systems like laboratory information systems, order entry systems, and electronic health records. HL7 defines a small library of structured message types. ADT carries patient demographic and movement data. ORM sends new test orders into the laboratory system. ORU carries completed lab results back to the electronic health record. When a lab analyzer completes a test, the laboratory information system constructs an ORU message containing the patient identifier, test code, result value, reference range, and any abnormal flag. That message travels through an interface engine and is passed by the EHR, posting the result to the patient's chart within seconds. HL7 is often confused with related standards. DICOM handles radiology imaging exchange, not lab results. FHIR is a newer HL7 family standard using web technologies, but older HL7 version 2 messages still dominate laboratory interfaces. ICD-10 is a diagnosis code system that rides inside HL7 messages. It is not the protocol itself. Whenever an exam stem describes a protocol moving laboratory results or patient movement data between hospital systems, the answer is Health Level 7, imaging exchange points to DACOM. HL7 is the protocol, ICD-10 is just a value inside it. Question 20. A patient is scheduled for routine venipuncture for a complete blood count. After the technician explains the procedure clearly, the patient simply rolls up his sleeve and extends his arm without saying a word. Which type of consent has the patient provided through this behavior alone? Your options are A. Implied consent, B. Informed written consent, C. Express written consent, D. No consent at all. Don't overthink it. Which one feels right? The correct answer is A. Implied consent. A is correct because implied consent is communicated by behavior rather than words, and rolling up a sleeve after explanation is the canonical phlebotomy example. The behavior covers only the routine procedure that was just described to the patient at bedside. B is wrong because informed written consent requires documented disclosure of risks, benefits, and alternatives, plus a patient's signature. Routine venipuncture in this scenario uses behavioral implied consent rather than the elaborate documentation reserved for higher risk procedures. C is wrong because express written consent requires the patient to sign a form, which has not occurred here. Routine venipuncture rarely requires written consent, and the scenario describes only behavioral communication without any pen and paper documentation step. D is wrong because treating the behavior as no consent ignores a recognized legal doctrine. The patient extended an arm after hearing the explanation, which courts and clinical ethics treat as a valid consent for the routine procedure described moments earlier. Implied consent is the legal doctrine that recognizes consent communicated through behavior rather than words. Understanding when and why it applies helps phlebotomists act confidently and ethically in routine encounters. The classic example is simple. After the phlebotomist explains the draw, the patient rolls up their sleeve and extends their arm. No signature, no verbal yes. The behavior itself satisfies the consent element, and courts recognize it as valid for this limited scope. Implied consent only holds when three conditions are met. First, a clear explanation of the procedure must precede the behavior. Second, the behavior must be unambiguous, not mere passivity. Third, the patient must have capacity, meaning they are alert, oriented, and legally able to decide. Consent law maps categories to risk levels. Implied consent covers routine low-risk procedures on capacitated adults. Higher risk or invasive procedures require expressed or informed written consent, where documented disclosure and a signature are mandatory. When a patient responds to a clear explanation with cooperative behavior, rolling up a sleeve, extending an arm, that is implied consent. Demanding a signature for routine venipuncture applies the wrong standard. Match the consent type to the procedure's risk level. Question 20. A patient brought a stool sample for Clostridioides difficile testing in a sealed cup, and the technician examines the consistency before processing. Which consistency matches the acceptable sample for toxin or PCR testing here in routine clinical practice today, in routine clinical phlebotomy practice? Your options are A. Formed stool only, B. Solid stool refrigerated overnight, C. Liquid or unformed stool, D. Rectal swab specimen. Got a guess? Lock it in. The correct answer is C. Liquid or unformed stool. C is correct because the assay requires liquid or unformed stool, since formed stool is associated with carriage rather than active infection. Laboratories reject formed specimens to avoid false positive results from asymptomatic colonization, which can occur in many hospitalized patients. A is wrong because formed stool only is explicitly the rejected sample type for this test. The clinical question is active infection, and formed stool typically reflects colonization rather than disease, so the assay is invalid on that consistency. B is wrong because solid stool refrigerated overnight remains formed stool and is still rejected. Refrigeration affects organism viability for some tests but does not change the consistency requirement for this assay, which centers on the active diarrheal state. D is wrong because a rectal swab is not the standard sample for routine toxin or PCR testing. Stool in a sealed cup is the accepted specimen, with liquid or unformed consistency, since swabs lack enough material for the assay. The consistency requirement for Clostridioides difficile testing is one of the most clinically important pre-analytical rules in the microbiology lab. It exists not as an arbitrary standard, but because stool consistency is a direct proxy for active disease versus asymptomatic colonization. C. Definite toxins can persist in the gut of patients who have no symptoms, especially after antibiotic exposure. Testing a formed stool specimen risks a positive result in a colonized patient, leading to unnecessary isolation and treatment with no clinical benefit. Active C. Disinfection is driven by toxin A and toxin B, which damage the colonic epithelium and disrupt water and electrolyte absorption. This toxin-mediated colitis is what produces the frequent watery stools that are the clinical signal the assay is designed to detect. At the bench, the technologist examines every C. diff specimen before processing. If stool pours or conforms to the container, it proceeds to the assay. If it holds its own shape, it is rejected and a redraw is requested. This is a quality decision backed by professional society guidelines, not a customer service issue. The consistency rule belongs exclusively to the C. diff assay. Routine stool cultures and ova and parasite exams accept any consistency because they ask only about organism presence. Fecal occult blood cards are commonly collected from formed stool and are entirely unrelated to C. diff testing. Question 25. A phlebotomy technician applies a tourniquet and turns to gather supplies, leaving the tourniquet in place for nearly 2 minutes while she finishes the antiseptic step. Which time limit matches in routine clinical practice today in routine clinical phlebotomy practice? Your options are A. 5 minutes, B. 1 minute, C. 10 minutes, D. 30 seconds. Which one is it? Pause the video if you need more time. The correct answer is B. 1 minute. B is correct because the standard limits tourniquet time to 1 minute before puncture. Beyond 1 minute, hemoconcentration develops and skews results, so the phlebotomist releases and reapplies after a 2-minute rest. This is wrong because a 5-minute limit far exceeds the standard and would cause significant hemoconcentration. Multiple analyte values would be artifactually elevated, which is why the standard sets a tighter window. C is wrong because a 10-minute limit is impossibly long and would produce serious specimen distortion. Hemoconcentration starts within minutes, and tissue ischemia could begin during such an interval. The standard reflects current practice in routine clinical phlebotomy. D is wrong because a 30-second limit is shorter than typical practice allows for palpation and preparation. The standard accepts up to a minute, balancing practical workflow with analyte stability concern. Every blood draw follows a 1-minute rule. The tourniquet must not stay on longer than 60 seconds before the needle enters the vein. This limit is grounded in physiology, not convention. When a tourniquet raises venous pressure, hydrostatic force pushes plasma water out of the vessel into the interstitial space faster than oncotic pressure can pull it back. Cells, large proteins, and protein-bound molecules stay behind in an increasingly concentrated sample, This is hemoconcentration. The 1 minute threshold comes directly from analyte stability data. Under 1 minute, changes are too small to matter clinically. By 2 minutes, hematocrit and protein-bound calcium have measurably risen. By 3 minutes, several chemistry analytes carry artifactual elevations that can mislead a clinician. If preparation extends beyond 1 minute, the phlebotomist releases the tourniquet, asks the patient to flex the hand to restore venous return, and waits a full 2 minutes before reapplying. Resetting the clock costs a small amount of time but preserves the integrity of the entire panel. The standard is clear. Tourniquet time before puncture must not exceed 1 minute. Anything longer introduces hemoconcentration error. Releasing and resetting is always the right call. Question 26. A phlebotomy technician is unsure how often to run 2-level controls on the clinic glucometer. The supervisor points to a specific document supplied by the manufacturer that defines the QC interval for the device. Which of the following documents sets the QC frequency? Your options are A. The manufacturer's instructions for use, B. The CDC isolation guideline, C. The OSHA HAZCOM standard, D. The CLSI venipuncture document. Take a second. Which answer would you pick? The correct answer is A. The manufacturer's instructions for use. A is correct because manufacturer instructions for use establish the QC frequency for any device, including the 2-level glucometer control schedule, CLIA, CAP, and the Joint Commission all require strict adherence to that schedule, with deviation reclassifying the test. B is wrong because CDC isolation guidance addresses transmission-based precautions, hand hygiene, and personal protective equipment. It does not specify glucometer QC schedules, which are device-specific and live within the manufacturer's documentation rather than infection control guidance. C is wrong because the OSHA Hazard Communication Standard covers chemical container labeling, safety data sheets, and employee chemical training. Glucometer QC frequency is not chemical hazard information, so the HAZCOM rule has no bearing on this control schedule question. D is wrong because the CLSI venipuncture document GP41 governs blood collection procedure rather than analyzer maintenance schedules. Glucometer QC frequency is set by the device manufacturer, not by a venous collection technical standard at all. When a laboratory needs to know how often to run quality control on a clinical device, there is one authoritative source, the manufacturer's instructions for use, or ICFU. Understanding why the IFU holds that authority and how it fits into the broader quality program is the key concept here. The IFU ships with every clinical device and covers QC frequency, control levels, calibration intervals, reagent storage, and troubleshooting. These specifications come directly from the manufacturer's validation studies. So Alassiet's Wadid aids, the research that defined the exact conditions under which the device performs accurately and precisely. The IFU establishes the minimum QC requirements, often 2-level controls every 24 hours for a glucometer. The laboratory's quality program layers on top, sometimes adding controls after events like a reagent lot change. CLIA, CAP, and the Joint Commission all inspect to confirm both the IFU minimums and the laboratory's own program are consistently followed. Common distractors each govern a real but different scope. The CDC isolation guideline covers transmission precautions. The OSHA Hazard Communication Standard addresses chemical labeling. CLSI GP41 governs blood collection technique. Safety data sheets describe reagent hazards. None of them set QC frequency for a clinical device. Only the manufacturer's IFU does that. Whenever an exam stem asks, what document governs QC frequency for a clinical instrument? The answer is the manufacturer's IFU. The lab SOP CLSI guidelines, and regulatory standards all support it, but the IFU sits at the top of the hierarchy. Question 27. A clinician orders a morning cortisol level to evaluate possible adrenal insufficiency. The technician understands that cortisol follows a strong diurnal rhythm, and timing matters for accurate interpretation against the reference range. Which collection window matches the standard expectation for a morning cortisol order? Your options are A. 1100 to 1300, B. 0700 to 0900, C. 0500 to 0600, D. 1700 to 1900. Before I reveal it, which one do you think is right? The correct answer is B. 0700 to 0900. B is correct because morning cortisol is collected between 0700 and 0900, the natural diurnal peak. The reference range was developed for this window, so a morning cortisol drawn outside it cannot be reliably interpreted clinically. A is wrong because 1100 to 1300 is mid-morning to early afternoon, beyond the diurnal cortisol peak. Reference ranges for that window do not exist for routine morning cortisol orders, so values would be uninterpretable against published norms. C is wrong because 0500 to 0600 is too early relative to the diurnal peak, and the reference range was not validated at that time. Drawing before the standard window introduces interpretive ambiguity around the value obtained. D is wrong because 1700 to 1900 is the afternoon window for evening cortisol levels, which are typically half the morning value. Drawing morning cortisol in the evening window misses the diurnal peak and uses the wrong reference frame. Cortisol secretion follows a predictable daily rhythm driven by the hypothalamic pituitary adrenal axis. Understanding this rhythm is essential for interpreting a single plasma cortisol result correctly. The suprachiasmatic nucleus signals the pituitary to release ACTH in pulses that peak in the early morning. The adrenal cortex responds with cortisol production that follows the same arc, rising sharply after waking, then declining steadily, reaching roughly half the morning value by late evening. The laboratory reference range was built from samples drawn at the diurnal peak, the 7A to 01900 window. A result drawn outside this window cannot be cleanly compared to that range and may be uninterpretable for the clinical question being asked. Only the 070 to 090 window matches the standard morning reference range. The 050 to 060 window is too early for the morning surge to complete. Mid-morning to early afternoon is past the peak, and the late afternoon window reflects a separately evaluated evening trough. When ordering a routine plasma cortisol, always specify the 07 to 0 draw window. A value drawn outside it lacks a matched reference range and cannot reliably confirm or exclude adrenal insufficiency. Question 28. A patient sitting in the draw chair becomes pale and diaphoretic 2 minutes into the venipuncture. The phlebotomy technician recognizes vasovagal prodromal signs. Which of the following actions should the technician take immediately in routine clinical practice today in routine clinical phlebotomy practice? Your options are A. Stop the draw and recline legs elevated. B. Continue the draw quickly. C. Walk the patient to fresh air. D. Offer hot coffee. What's your answer? Commit to one before I continue. The correct answer is A. Stop the draw and recline legs elevated. A is correct because the recommended response is to stop the draw, safely remove the needle, recline the chair fully, and elevate the legs to support venous return. A cool, damp cloth and observation for 15 minutes complete the recovery period afterward. B is wrong because continuing the draw quickly risks a complete syncopal event with possible fall and injury. Patient safety requires stopping the procedure to prevent loss of consciousness, since needle presence during a fall could cause additional puncture trauma. C is wrong because walking the patient to fresh air is unsafe during prodromal syncope, since loss of consciousness during ambulation may produce a fall. Reclining and elevating legs is the established response, with fresh air not part of any current guideline. D is wrong because offering hot coffee adds a hot liquid risk during impending loss of consciousness and provides no physiologic benefit. The proper management is positional and supportive, with oral intake reserved for full recovery rather than the prodromal phase itself. When a patient shows early warning signs of a vasovagal episode during a draw, a specific sequence of actions interrupts the reflex before consciousness is lost. Understanding why each step works helps you respond correctly every time. The vasovagal reflex slows the heart and dilates peripheral vessels at the same time. Cardiac output drops, blood pressure falls, and cerebral perfusion follows. Pallor reflects falling skin perfusion, while diaphoresis signals parasympathetic activation. These warning signs come before consciousness is lost. Acting on these prodromal signs is the entire goal. If you recognize pallor, diaphoresis, lightheadedness, or yawning and respond immediately, the syncopal event never completes, and the risks of a fall and needle injury are avoided entirely. The response runs in order: stop the draw, safely withdraw the needle with gauze pressure, then recline the chair and raise the legs. Reclining to supine and elevating the legs restores venous return to the heart and supports cerebral perfusion through the position change alone. The wrong answers feel intuitive, but each adds risk. Continuing the draw invites full syncope. Walking the patient risks a fall during ambulation. Hot coffee introduces a burn hazard with no physiologic benefit. Only reclining with leg elevation addresses both the autonomic reflex and the fall risk simultaneously. Question 29. A phlebotomy technician underfills a light blue coagulation tube to about 60% of the labeled draw volume. The lab calls back asking why prothrombine time looks critically high. The technician understands the underfill mechanism well. Which of the following effects does the underfill produce? Your options are A. Hemolysis only, B. Falsely shortened PT, C. No effect, D. Falsely prolonged PT. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is D. Falsely prolonged PT. D is correct because an underfilled citrate tube has excess anticoagulant relative to plasma, prolonging prothrombin time falsely. The reported value would suggest unnecessary fresh frozen plasma transfusion if the clinician trusted it. A is wrong because hemolysis describes red cell lysis releasing hemoglobin, unrelated to citrate underfill. Hemolysis arises from collection technique, agitation, or transport stress, not citrate to plasma ratio. The standard reflects current practice in routine clinical phlebotomy. B is wrong because falsely shortened prothrombin time is the opposite of what underfill produces. Excess citrate prolongs rather than shortens the assay, which is why labs reject underfilled tubes. The standard reflects current practice in routine clinical phlebotomy. C is wrong because claiming no effect on prothrombin time ignores the chemistry. The citrate to plasma ratio is engineered for 9:1, and underfill above 10% skews reported clotting times noticeably. When a sodium citrate tube is underfilled, the prothrombin time comes back falsely prolonged. Understanding why requires looking at the chemistry built into the tube itself. The tube is engineered for 9 parts plasma to 1 part citrate. Citrate chelates calcium, preventing clotting during storage. When the tube is underfilled, the ratio shifts, so there is more citrate per unit of plasma. The assay reverses chelation by adding calcium back at the start of the test, but excess citrate from the underfill binds more of that added calcium, leaving less free calcium to drive the clotting cascade. So the measured clotting time stretches longer than the patient's true physiology. It is worth separating citrate underfill from other pre-analytical errors. Hemolysis, hemoconcentration, and lipemia each distort different analytes through completely different mechanisms. None of them prolongs PT the way citrate underfill does. Laboratories reject underfilled citrate tubes because a falsely prolonged PT could mislead a clinician into ordering unnecessary fresh frozen plasma. The 90% fill threshold exists precisely to keep the 9-to-1 ratio intact and the result interpretable. Question 30. A new technician is choosing between pour-off and pipetting for transferring serum from an SST primary tube to an aliquot tube. The supervisor reviews the situations that favor each technique based on volume, precision needs, and the presence of separator gel. Which of the following scenarios favors pour-off? Your options are A. Sending out reference tests requiring exact volume. B. Routine SST aliquot approximate volume. C. Multiple aliquots of differing volumes. D. Tube with no gel and loose cells. Which would you go with? Lock it in before the reveal. The correct answer is B. Routine SST aliquot approximate volume. B is correct because pour-off works well for routine aliquot transfer from an SST, where volume is approximate and the gel barrier prevents cell carryover. The technique is fast and reduces aerosol generation compared with pipetting. A is wrong because sending out a reference test requiring exact volume favors pipetting rather than pour-off. Calibrated transfer pipettes provide precise volume control, which the gravity pour cannot match reliably. C is wrong because multiple aliquots of differing volumes favor pipetting because each volume can be precisely measured. Pour-off cannot deliver several different specific volumes from a single primary tube. The standard reflects current practice in routine clinical phlebotomy. D is wrong because tubes with no gel and loose cells favor pipetting to avoid drawing cells with serum. Pour-off would risk transferring cells during the gravity tilt, distorting downstream chemistry results. When moving serum or plasma from a primary tube into an aliquot tube, the laboratory chooses between two transfer techniques, pour-off and pipetting. The choice is driven by the test requirement, not personal preference. Pour-off is fast, requires no pipetting equipment, and relies on the gel barrier in an SST tube to keep cells away from the serum. Pipetting is slower but delivers a measured, exact volume, essential for reference tests or tubes lacking a gel barrier. During pour-off, the tube tilts and gravity carries serum across the gel surface, while the gel acts as a check valve, keeping cells trapped below. During pipetting, the tip is lowered only into the serum layer, aspirating a calibrated volume without ever contacting the cellular layer beneath. The exam tests whether you can match the technique to the clinical scenario. Routine SST aliquots with approximate volumes call for pour-off. Any scenario requiring an exact volume, a specialized send-out test, or a tube without a gel barrier calls for pipetting. Remember, when precision and exact volume are demanded by the test, pipette. When speed and an SST gel barrier are in play, pour-off is the standard. Let the test requirement drive the decision every time. Question 31. A phlebotomy technician is choosing between an evacuated tube draw and a syringe draw for a chemotherapy patient with very fragile collapsible veins. She wants the technique that lets her control suction manually so the vein does not collapse. Which of the following approaches fits best? Your options are A. Needle and syringe. B. 16 gauge straight needle. C. Standard evacuated tube system. D. Capillary heel stick. Don't overthink it. Which one feels right? The correct answer is A. Needle and syringe. A is correct because the needle and syringe method allows the phlebotomist to control suction by manual plunger speed. Slow withdrawal prevents collapse of fragile chemotherapy veins under the higher vacuum of an evacuated tube. B is wrong because a 16 gauge straight needle is sized for blood donation and would tear small fragile veins. The high flow needle creates excess vacuum and turbulence chemotherapy veins cannot tolerate. C is wrong because the standard evacuated tube system applies fixed high vacuum that collapses fragile veins. Switching to manual aspiration with a syringe directly addresses the vacuum issue in this clinical situation. D is wrong because a capillary heel stick on the foot is not appropriate for adult routine venous chemistry orders. Heel sticks are reserved for newborns rather than adult chemotherapy patients receiving routine labs. When a patient has fragile or collapsing veins, the standard evacuated tube system can actually make things worse. Understanding why requires a look at how vacuum and suction work during a blood draw. An evacuated tube applies a fixed internal vacuum the moment it engages the holder. A small or fragile vein simply cannot deliver blood fast enough, and the vessel collapses inward. A syringe, by contrast, generates only the suction the operator chooses, and the operator can pause, slow, or reverse at any time. Visually, the difference is straightforward. Under fixed tube vacuum, the vein wall is pulled inward and the lumen closes off. With a syringe, the operator controls exactly how much negative pressure is applied, keeping the lumen open throughout the draw. The technique follows a careful sequence. First, confirm the plunger moves freely before venipuncture. Enter bevel up at a shallow angle and watch for a flash at the hub. If the vein collapses at any point, pause, let the vein refill and resume pulling at a slower rate. Common distractors all share one flaw. They do not put suction control in the operator's hand. A 16 gauge needle tears fragile veins. A butterfly with a tube holder still applies fixed vacuum. Even low vacuum pediatric tubes reduce rather than eliminate the problem. Only the needle and syringe approach genuinely lets the vein dictate the rate. Question 30A. A processing technician is shipping a routine diagnostic blood specimen to a reference laboratory by ground transport. IATA classifies routine patient diagnostic specimens that are not Category A pathogen cultures. Which of the following IATA categories and UN numbers matches routine diagnostic patient specimens? Your options are A. U284 Category A, B. UN 3373 Category B, C. UN 1855 dry ice classification, D. Exempt human specimen only. Got a guess? Lock it in. The correct answer is B. UN 3373 Category B. B is correct because routine diagnostic patient specimens ship as UN 3373 Category B. Biological substance, Category B. The classification covers most clinical specimens that do not meet the high-risk Category A pathogen criteria. A is wrong because UN 2814 Category A applies only to cultures of high-risk pathogens like Yersinia pestis or Ebola virus. Routine diagnostic patient specimens ship as Category B rather than this higher tier. C is wrong because UN 1845 is the dry ice classification used as a refrigerant rather than a specimen category. Dry ice can accompany Category B specimens, but the specimen itself ships as UN 3373 biological substance. D is wrong because exempt human specimen applies to specimens with minimal pathogen likelihood like routine wellness screening. Most diagnostic specimens ship as UN 3373 Category B unless specifically known to be exempt. When routine diagnostic patient specimens are shipped to a reference laboratory by ground or air, they fall under a specific international classification designed to standardize how infectious biological material is handled in transit. IATA and ICAO rules divide infectious substances into two main categories. Category A covers dangerous high-risk pathogen cultures. Category B covers everything else routine, the vast majority of specimens sent to reference labs every day. Exempt human specimen applies only when pathogen likelihood is minimal. Packing Instruction 650 mandates a triple-layer system. The primary container holds the specimen itself. The secondary container adds a leak-proof layer with absorbent material to contain any spillage. The rigid outer box carries the UN 3373 diamond label, along with shipper information and required documentation. Four classifications are commonly confused on exams. UN 3373 Category B is correct for routine diagnostic specimens. UN 2814 Category A applies only to high-risk pathogen cultures. WIN 1845 is the dry ice classification. It may accompany a shipment as a refrigerant but is never the specimen category itself. Exempt human specimen applies only under narrow low-risk criteria. Whenever an exam stem describes routine patient specimens heading to a reference laboratory, the answer is UN 3373 Category B. Reserve Category A for dangerous pathogen cultures. And never confuse the dry ice or exempt classifications for the specimen category itself. Question 33. A morning sweep includes 3 stat requisitions for inpatients on different floors. The technician is currently completing a routine draw at one bedside when she receives the alert. Which interpretation matches standard phlebotomy practice for handling stat priority orders here in routine clinical practice? Your options are: act within 24 hours. B. Drop everything immediately and run. C. Next up after current bedside duty. D. After morning rounds finish. Which one is it? Pause the video if you need more time. The correct answer is C. Next up after current bedside duty. C is correct because stat means within roughly 1 hour of order to result, which translates to next up after current bedside duty. The phlebotomist completes the live patient encounter safely, then moves to the stat request immediately afterward. A is wrong because treating stat as a 24-hour priority describes the routine timeline rather than the urgent one. Stat cases need handling within roughly an hour, not a full-day window, which would defeat the priority code. B is wrong because dropping everything immediately and running risks abandoning the live patient mid-draw with a needle still in place. Stat does not mean abandon current duties, since safety considerations still apply to whoever is currently on the chair. D is wrong because waiting until morning rounds finish would push the stat well beyond the 1 hour window. Stat requests must be handled promptly after the current encounter rather than batched into the routine schedule for later attention. A stat laboratory order is a priority designation, meaning the test must move from order to result within roughly 1 hour. Understanding how phlebotomists handle a stat request during an active draw is the key principle the exam tests. The rule balances urgency against immediate patient safety. A stat request moves to the front of the queue, but the front of the queue only starts after the active venipuncture is safely completed. Needle out, pressure applied, patient stable. When the stat alert arrives mid-draw, the phlebotomist acknowledges it without changing pace. She completes the active draw, removes the needle, bandages the site, confirms the patient is stable, and then immediately redirects to the stat encounter. Stat sits at the most urgent end of the priority spectrum. ASAP orders fall between stat and routine, while timed orders must hit a specific clock window rather than a turnaround target. Knowing where each code lands prevents confusing them on the exam. The exam rejects both extremes. abandoning an active draw creates immediate patient risk, and delaying stat beyond 1 hour defeats the priority code entirely. Finish the current bedside duty safely, then move to stat immediately. Question 34. A specific accessory device must be used to inoculate bottles safely from a syringe rather than pushing blood through a needle and septum directly. Which of the following devices fits this role in routine clinical phlebotomy practice for the routine adult outpatient draw? Your options are A. Multi-sample lure adapter, B. Capillary tube collector, C. Microhematocrit centrifuge, D. Single-use blood transfer device. Take a second. Which answer would you pick? The correct answer is D. Single-use blood transfer device. D is correct because the single-use blood transfer device replaces the syringe needle with a sheathed cannula that pierces the bottle septum safely. Vacuum draws blood from the syringe, preventing splash and pressurization injuries. A is wrong because the multi-sample lure adapter connects a butterfly to a tube holder rather than handling syringe to bottle transfer. It is a different accessory that does not fit the syringe inoculation scenario. B is wrong because a capillary tube collector is for capillary blood collection from finger sticks or heel sticks. It has no role in syringe to bottle transfer of venous specimens for cultures. C is wrong because a microhematocrit centrifuge is for spinning capillary tubes to determine hematocrit. It is unrelated to syringe to bottle transfer for blood cultures and serves a hematology function only. After a syringe draw, getting blood safely into evacuated tubes requires a specialized accessory. The single-use blood transfer device was designed specifically to solve the hazards that arose before standardized transfer methods existed. Before transfer devices were standardized, operators would recap or swap needles between steps, generating needle stick injuries at high rates. Pushing blood through a needle into a tube also risks splash exposures. The transfer device eliminates both hazards entirely. The device threads onto the syringe's lure fitting, replacing the original needle. Its sheathed cannula pierces the tube septum, and the tube's own vacuum draws blood from the syringe. The operator never touches a sharp surface and never pushes the plunger. 4 accessories are commonly confused. The blood transfer device bridges a syringe to evacuated tubes. The multi-sample lure adapter connects a butterfly to a tube holder. A capillary collector serves fingerstick or heel stick collection. A transfer pipette moves serum or plasma after centrifugation. Only the blood transfer device handles the post-draw syringe to tube step. When any exam STEM describes transferring blood from a syringe into evacuated tubes or culture bottles, the answer is always a single-use blood transfer device. It is the only accessory built for that specific step, and it discards directly into the sharps stream when the transfer is complete. Question 35. A phlebotomy technician evaluates a patient's antecubital fossa and considers the CLSI vein hierarchy for a routine venipuncture. She palpates each candidate vein and weighs its risks before selecting the entry site for the draw. Which vein matches the first choice antecubital vein according to standard CLSI guidance? Your options are A. Median cubital, B. Cephalic, C. Basilic, D. Brachial artery. Before I reveal it, which one do you think is right? The correct answer is A. Median cubital. A is correct because the median cubital vein is the first choice because it sits centrally and tends to be the largest. Its location away from the brachial artery and median nerve makes it the safest selection in routine practice. B is wrong because the cephalic vein is the second choice on the lateral side. It is acceptable when the median cubital is not viable, but its tendency to roll makes it less ideal as the routine first-line selection. C is wrong because the basilic vein is the third and last choice, because it lies adjacent to the brachial artery and median nerve. Its anatomic position makes accidental arterial puncture or nerve injury more likely, which is why it ranks last. D is wrong because the brachial artery is not a venous draw target at all and would be punctured intentionally only for arterial blood gas. Targeting the artery during venipuncture would cause arterial bleeding and a hematoma, with possible aneurysm formation later. When choosing a vein for routine venipuncture, the Clinical and Laboratory Standards Institute ranks the 3 antecubital options by safety and reliability. Understanding why each vein earns its rank helps you apply the hierarchy correctly under pressure. The antecubital fossa contains 3 usable superficial veins. The median cubital sits centrally. The cephalic runs laterally along the thumb side, and the basilic runs medially, directly adjacent to the brachial artery and the median nerve. The CLSI ranks the median cubital first because it is the largest, most anchored, and farthest from critical structures. The cephalic is second but more prone to rolling. The basilic is last, used only when the first 2 are not viable, because it lies next to the brachial artery and median nerve, raising the risk of arterial puncture or nerve injury. 3 qualities put the median cubital at the top: size for reliable flash and flow, stability because surrounding connective tissue anchors it against rolling, and safety because its central position keeps it away from the brachial artery and the median nerve. Always assess in hierarchy order. If the median cubital is palpable and anchored, draw there. Step down to the cephalic only if needed, and reserve the basilic as the last antecubital resort before moving to dorsal hand veins with a butterfly. Question 36. A phlebotomy technician preparing a nasopharyngeal swab for respiratory virus testing inserts the flexible flocked swab. The recommended insertion technique targets the nasopharynx safely without injuring the cribriform plate or adjacent structures. Which of the following techniques matches the standard nasopharyngeal swab insertion approach? Your options are: A. Insert pointing upward toward eyes. B. Insert at 30 degrees. C. Insert parallel to floor of nose. D. Insert pointing downward to the mouth. What's your answer? Commit to one before I continue. The correct answer is C. Insert parallel to floor of nose. C is correct because the standard inserts the swab parallel to the floor of the nose, advancing to the depth of the earlobe. The horizontal angle avoids the cribriform plate and the eye while reaching the nasopharynx. A is wrong because inserting upward toward the eyes risk injury to the cribriform plate and adjacent structures. The horizontal floor of the nose approach is safer and reaches the nasopharynx without complications. B is wrong because inserting at 30 degrees is steeper than recommended and risk injury to surrounding structures. The standard floor of the nose technique uses a horizontal trajectory rather than any upward angle. D is wrong because inserting pointing downward to the mouth misses the nasopharynx and reaches the oropharynx instead. The standard targets the nasopharynx with a horizontal trajectory along the nasal floor. The standard reflects current practice in routine clinical phlebotomy. Collecting a nasopharyngeal swab correctly depends on understanding the anatomy of the nasal cavity and following a precise insertion trajectory. Getting the angle wrong risks missing the target entirely or causing serious injury. The nasal cavity floor is formed by the hard palate, and the roof is partly formed by the cribriform plate of the ethmoid bone. The swab travels horizontally from the nostril to the posterior nasopharynx, staying well below the cribriform plate and above the dental structures. Angling the swab upward toward the eyes risks injuring the cribriform plate, which can cause a cerebrospinal fluid leak. Angling downward misses the nasopharynx and reaches the oropharynx instead. Only the horizontal trajectory stays in the safe corridor. In practice, the clinician inspects both nostrils and selects the more patent side. The flocked swab is then advanced horizontally along the floor of the nose until resistance is felt at the posterior nasopharynx, roughly earlobe depth. The swab is rotated for several seconds, then withdrawn and placed into viral transport medium. Whenever a question describes nasopharyngeal swab technique, the correct answer is always parallel to the floor of the nose, advanced to the depth of the earlobe. Any upward or downward deviation is either contraindicated or off target. Question 37. A phlebotomy technician preparing the equipment for an arterial blood gas draw selects the heparin in the syringe carefully. The therapist explains that one specific heparin formulation is preferred to avoid falsely elevating sodium when the same syringe is later used for chemistry. Which of the following heparins matches? Your options are A. Sodium heparin, B. Lithium heparin, C. Ammonium heparin, D. Heparin-free saline. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is B. Lithium heparin. B is correct because lithium heparin is the preferred ABG syringe additive because it does not falsely elevate sodium results if the same specimen is later run for chemistry. The lithium is small enough not to interfere with most chemistry assays. A is wrong because sodium heparin would falsely elevate sodium results if the specimen were later analyzed for chemistry. The standard prefers lithium heparin specifically to avoid this interference in the assay. C is wrong because ammonium heparin would falsely elevate ammonia and is not used in arterial blood gas syringes. Lithium remains the standard heparin formulation for the ABG syringe across most institutions. D is wrong because heparin-free saline would not anticoagulate the specimen and the blood would clot before analysis. Lithium heparin is the standard since the syringe must be coated with anticoagulant before draw. When arterial blood is drawn for blood gas analysis, the choice of anticoagulant matters far beyond simply preventing clotting. The additive's chemical identity can silently falsify downstream chemistry results, which is why the standard calls for lithium heparin specifically. The ABG syringe comes pre-coated with a small amount of dried lithium heparin on its inner surface. As arterial blood fills the barrel, the heparin dissolves and mixes throughout, anticoagulating the specimen by the time the draw is complete. The interference is straightforward. Sodium heparin adds sodium ions to the specimen, artificially elevating the reported sodium. Ammonium heparin adds ammonium, falsely raising ammonia, a critical measurement in liver disease and hepatic encephalopathy workups. Lithium heparin works because the lithium counter ion is small, present in negligible amounts, and invisible to common chemistry assays. This means a single syringe can safely provide both blood gas values and clean electrolyte results, a major advantage in critical care workflows. Remember, the blood gas analyzer tolerates any heparin for gas tensions, but lithium heparin is the only form that protects downstream chemistry. When a STEM asks for the preferred ABG syringe additive, lithium heparin is always the answer. Question 38. A patient scheduled for an early morning fasting glucose asks if her routine antihypertensive can still be taken with a small sip of water. The technician understands medication permissions during a fast vary by order. Which approach best matches standard pre-analytical practice for this scenario? Your options are A. Tell her medications are always banned. B. Tell her to skip all medications. C. Tell her to take it anyway. D. Refer her to the ordering provider. Which would you go with? Lock it in before the reveal. The correct answer is D. Refer her to the ordering provider. D is correct because medication handling during fasting depends on the order and the medication, decided by the ordering provider rather than the phlebotomist. The phlebotomist refers the question upstream so the provider can authorize or hold medications appropriately. A is wrong because telling the patient medications are always banned over generalizes and contradicts most fasting protocols, which permit routine medications unless specifically held. Categorical denial could harm a patient whose antihypertensive should continue right up to the draw window. B is wrong because telling the patient to skip all medication steps outside phlebotomy scope and risk clinical harm. Some medications must continue around procedures, and a phlebotomist directing a patient to skip them practices outside scope dangerously. C is wrong because telling the patient to take it without checking still steps outside scope, even if the answer is often correct. The phlebotomist must defer to provider authority on medication decisions, especially when patients ask before any clarification arrives. When a fasting patient asks whether to take a routine medication before a draw, that question does not belong to the phlebotomist. It belongs to the ordering provider. Understanding why and how to route it correctly is the core of this concept. The phlebotomist's scope covers collection technique, patient identification, and pre-analytical handling. Medication permissions during fasting depend on the specific test, the medication, the patient's clinical status, and dose timing, decisions that sit firmly within the prescriber's scope. Answering either way creates patient risk. Telling a patient to take the medication could interfere with a test or a perioperative hold the phlebotomist doesn't know about. Telling the patient to skip it could withhold therapy that must continue. Both directions cross into prescribing territory. The correct technique is to acknowledge the question, explain that the answer depends on the order and the medication, and offer to contact the ordering provider's office. If the patient has already taken the medication, the phlebotomist documents that fact so the lab can interpret the result accurately without making a clinical decision. Holding the line on scope is not just a rule, it is patient safety. The right response to any medication question during a fast is a clean referral to the ordering provider. That one habit protects the patient, the result, and the phlebotomist. Question 39. A phlebotomy technician removes a paper requisition from the printer and walks away to greet a patient, leaving the slip face up on an unattended phlebotomy cart in a public hallway. Which of the following is the most likely violation flagged by an auditor? Your options are A. CLIA record-keeping deficiency, B. CDC isolation breach, C. HIPAA confidentiality violation, D. CUP proficiency testing failure. Don't overthink it. Which one feels right? The correct answer is C. HIPAA confidentiality violation. C is correct because unattended requisitions in a public space expose protected health information to anyone passing by, which directly violates HIPAA confidentiality protections. Auditors flag this as a privacy breach with potential civil penalty exposure for the employer. A is wrong because CLIA record keeping focuses on test logs, calibration history, and personnel competencies rather than how requisitions are physically secured. The visible exposure here is a privacy issue, not a CLIA documentation gap by any reading. B is wrong because CDC isolation guidance covers transmission of infectious agents, including precaution categories and personal protective equipment. A paper requisition on a cart presents no biological transmission concern, so isolation framework does not apply here. D is wrong because CUP proficiency testing concerns the analytical performance of laboratory testing on blinded mailed specimens. Leaving requisitions visible has nothing to do with proficiency testing performance, which is measured by accurate analytical reporting through the program. When printed patient information is left visible in a public area, the governing framework is HIPAA, specifically the privacy rule. understanding why requires knowing what counts as protected health information, and how the rule applies to physical documents, not just electronic records. A printed requisition is unambiguously PHR because it typically contains the patient's name, medical record number, ordered tests, and diagnosis codes. The privacy rule defines PHI broadly: any individually identifiable information tied to a patient's health, treatment, or payment qualifiers, regardless of whether it appears on paper or a screen. The classic scenario is an unattended cart in a public corridor with requisitions lying face up. Anyone walking past can read patient names and ordered tests. Turning documents face down, using a covered tray, or keeping the cart out of public sight are the operational fixes the privacy rules workforce training emphasizes. A key exam skill is separating HIPAA from other laboratory frameworks. CLI-A governs analytical quality and personnel competency. CDC covers infection control and pathogen transmission. CAP addresses proficiency testing and accreditation. None of these touch paper requisition handling in a public space. That is exclusively a HIPAA confidentiality matter. Negligent exposure is enough to constitute a breach. No malicious intent is needed. Whenever a STEM describes printed PHI visible in a public area, the answer is a HIPAA privacy rule violation. Question 40. A laboratory manager wants to target quality improvement projects toward the phase that produces the largest share of laboratory errors, including ordering, identification, collection, and transport. Which of the following percentages best matches that share in routine clinical practice today in routine clinical phlebotomy practice? Your options are A. About 10 to 20%, B. About 30 to 40%, C. Roughly 90%, D. About 60 to 70%. Got a guess? Lock it in. The correct answer is D, about 60 to 70%. D is correct because published patient safety literature attributes about 60 to 70% of laboratory errors to the pre-analytical phase, which includes test ordering, patient identification, specimen collection, and transport. Phlebotomy is the dominant component of that phase. A is wrong because 10 to 20% describes the analytical phase contribution, where modern automation has driven errors lower. The pre-analytical phase remains the dominant error source, which is why patient identification training receives so much focus today. B is wrong because 30 to 40% is closer to the post-analytical share when reporting and interpretation errors are included. It still understates the pre-analytical contribution, which dwarfs the other phases in published medical error analyses today. C is wrong because 90% overstates any single phase contribution, since errors are distributed across all three phases. No published estimate supports a 90% attribution to the pre-analytical phase, even with generous definitions of error categories. The pre-analytical phase is the largest single source of laboratory errors, not because instruments fail, but because humans perform many steps across many settings before a specimen ever reaches the analyzer. The pre-analytical phase accounts for 60 to 70% of all lab errors, roughly 2/3. The analytical phase, driven down by automation and internal quality control, contributes only 10 to 20%. The post-analytical phase adds 30 to 40% through reporting and interpretation issues. The pre-analytical phase spans test ordering, patient identification, specimen collection, labeling, transport, and arrival at the laboratory. Each step is performed by humans in varied settings, creating many opportunities for error before automation ever takes over. The most common pre-analytical errors cluster into 4 categories: patient misidentification, wrong tube selection, improper draw technique causing hemolysis or contamination, and mislabeling or improper transport. Quality programs design specific countermeasures for each category, which is why phlebotomy training and specimen handling protocols are central to any laboratory quality program. When an exam stem asks which phase contributes the most errors, the answer is pre-analytical at 60 to 70%. Improving phlebotomy operations yields the largest measurable reduction in total laboratory error rate. Question 41. A phlebotomy technician completes an outpatient draw and is bandaging the site for a patient on warfarin who reports easy bruising. Which of the following instructions best matches standard guidance in routine clinical practice at the bedside in routine clinical phlebotomy practice? Your options are A. Remove bandage in 15 minutes. B. Drive immediately if feeling fine. C. Keep bandage on, watch for bleeding. D. Apply heat to site immediately. Which one is it? Pause the video if you need more time. The correct answer is C. Keep bandage on, watch for bleeding. C is correct because anticoagulated patients should keep the bandage on for several hours. Avoid heavy lifting on that arm and watch for delayed bleeding or hematoma. The instructions reduce bleeding risk and help recognize warning signs. A is wrong because removing the bandage in 15 minutes is too soon for an anticoagulated patient with prolonged bleeding tendency. The bandage should remain longer to support hemostasis at the site. B is wrong because telling the patient to drive immediately ignores residual bleeding risk and any vasovagal precaution. Standard instructions advise observation before leaving and longer activity precautions. The standard reflects current practice in routine clinical phlebotomy. D is wrong because applying heat immediately to the puncture site can worsen bleeding by promoting vasodilation. The standard sequence avoids heat in the immediate post-draw window for anticoagulated patients. The standard reflects current practice in routine clinical phlebotomy. When a patient is on anticoagulants, standard post-draw discharge instructions aren't enough. The puncture site sealed by initial hemostasis is inherently less stable, so the conversation at the chair must cover several specific points before the patient leaves. Warfarin reduces vitamin K-dependent clotting factor synthesis over days. Heparin and direct oral anticoagulants target different points in the coagulation cascade. Antiplatelet drugs like aspirin and clopidogrel impair platelet function for several days, meaning the sealed puncture site remains at risk long after the patient leaves the chair. The phlebotomist walks the patient through 3 points before discharge. First, keep the bandage on for at least 4 hours, replacing it if saturated. Second, avoid heavy lifting or repetitive arm motion for the rest of the day. Third, watch for swelling or active bleeding, and apply firm pressure for 10 minutes if bleeding restarts. Several plausible sounding answers are wrong for anticoagulated patients. Removing the bandage in 15 minutes is too soon even if hemostasis looked complete. Immediate driving ignores residual bleeding risk. Applying heat promotes vasodilation and worsens bleeding. Ice packs address an established hematoma. They are not primary prevention. Whenever a STEM identifies an anticoagulated patient and asks for the correct discharge instruction, the right answer pairs keeping the bandage on for at least 4 hours with explicit instructions to watch for delayed bleeding or hematoma formation. Question 42. A phlebotomy technician new to the facility is told the OSHA Bloodborne Pathogens standard requires the employer to offer a vaccine series at no cost within 10 working days of starting work. Which of the following vaccines and arrangements does the standard require? Your options are A. Hepatitis B vaccine offered free. Influenza vaccine mandatory. C. Tetanus booster within 10 days. D. HPV vaccine offered to all. Take a second, or which answer would you pick? The correct answer is A. hepatitis B vaccine offered free. A is correct because the standard requires employers to offer the 3-dose hepatitis B vaccine series free within 10 working days of initial assignment. Employees may decline by signing a specific form, but later request the vaccine free. B is wrong because influenza vaccination is recommended in many healthcare settings, but is not required under the Bloodborne Pathogens standard. Many employers mandate flu vaccination through separate workplace policies, which differ from the OSHA hepatitis B offer requirement. C is wrong because a tetanus booster is good general health practice but is not covered by the Bloodborne Pathogens rule. The standard targets pathogens transmitted through blood and OPM, and tetanus is not within that exposure scope at all. D is wrong because HPV vaccine is recommended by public health agencies for sexually transmitted papillomavirus protection, not for occupational bloodborne exposure. The OSHA standard targets hepatitis B because of its high concentration in blood and proven occupational risk. The OSHA bloodborne pathogen standard places a specific obligation on employers when it comes to hepatitis B vaccination. Understanding why hepatitis B is singled out, and exactly what the standard requires, is the key to answering exam questions on this topic. The employer must offer the hepatitis B vaccine series at no cost within 10 working days of the employee's initial assignment to an exposure risk role. The series follows a 3-dose schedule at 0, 1, and 6 months, followed by a post-vaccination antibody titer to confirm immune response. If the employee declines, they must sign a specific declination form kept in their record. Hepatitis B was targeted because the transmission risk from a single needle stick is far higher than for hepatitis C or HIV. So, up to 30% per exposure, the virus circulates at extremely high concentrations in infected blood, and a safe, effective vaccine has been available since the early 1980s, making prevention both practical and highly effective. Influenza, tetanus, LAV, and tuberculosis screening programs are real and important in healthcare settings, but none of them fall under the OSHA bloodborne pathogen standards required offer. When an exam stem describes a free vaccine, the employer must provide to bloodborne exposure workers. The answer is hepatitis B, not any of these. Whenever you see an exam question about vaccines required under the OSHA bloodborne pathogen standard, the answer is always hepatitis B, free to the employee, offered within 10 working days, documented in the exposure control plan, and every other vaccine falls outside the specific rule. Question 43. A coagulation tube returns to the technician's bench underfilled at 60% of the labeled draw volume. The lab calls back asking why the prothrombin time is critically high. The technician understands the underfill mechanism well from her training. Which effect on coagulation testing does this underfill produce? Your options are A. Hemolysis only, B. Falsely shortened PT, C. Falsely prolonged PT, D. No effect on PT. Before I reveal it, which one do you think is right? The correct answer is C. Falsely prolonged PT. C is correct because an underfilled citra tube has excess anticoagulant relative to plasma, which prolongs the measured prothrombin time falsely. The reported value would suggest unnecessary fresh frozen plasma transfusion if the clinician trusted the result without redrawing. A is wrong because hemolysis describes red cell lysis releasing hemoglobin, which is unrelated to citrate underfill. Hemolysis arises from collection technique, agitation, or transport stress, not from the citrate to plasma ratio that drives the coagulation assay distortion here. B is wrong because falsely shortened prothrombin time is the opposite of what underfill produces. Excess citrate prolongs rather than shortens the assay, which is why the laboratory rejects underfilled coagulation tubes and asks for a redraw before reporting. D is wrong because claiming no effect on prothrombin time ignores the chemistry. The citrate to plasma ratio is engineered for 9:1, and underfill above 10% invalidates that ratio enough to skew reported clotting times noticeably. When a coagulation tube is underfilled, the citrate to plasma ratio is thrown off, and the result that reaches the clinician no longer reflects the patient's true physiology. Understanding why this matters requires tracing the path from a mishandled tube all the way to an unnecessary transfusion. In a citrate tube, the anticoagulant volume is fixed. When there is less plasma than the tube was calibrated for, excess citrate chelates calcium used in the clotting assay, artificially prolonging the prothrombin time and elevating the INR. The decision pathway is dangerously short. A clinician seeing a critically elevated INR in an acute setting acts immediately, ordering fresh frozen plasma or reversal therapy without pausing to question whether the tube was underfilled. The laboratory is the only checkpoint that can break this chain. Detection is straightforward if applied consistently. The technologist checks every coagulation tube against the labeled fill mark. Tubes below the acceptance threshold, typically 90% of labeled volume, are rejected, logged, and a redraw is requested before any result is reported. Coagulation tubes are uniquely vulnerable because the entire assay calibration depends on that precise citrate to plasma ratio. Heparin, lavender, and serum separator tubes are far more tolerant of volume variation, which is why fill volume rules are strictest and most consequential for citrate tubes. Question 44. A new charge nurse is reviewing an exposure control plan and notes the document was last updated almost 20 months ago. Which of the following review schedules does the OSHA Bloodborne Pathogens standard require in routine clinical practice today in routine clinical phlebotomy practice? Your options are A. Every 5 years, B. Every 3 years, C. Every 6 months, D. Annually and when tasks change. What's your answer? Commit to one before I continue. The correct answer is D. Annually and when tasks change. D is correct because the exposure control plan must be reviewed annually and whenever new tasks, procedures, or technologies affect occupational exposure. The Needle Stick Safety and Prevention Act reinforced this cadence to keep safer device evaluation current and effective. A is wrong because a 5-year review would let outdated procedures persist long after safer technologies became available. The federal cadence is much more frequent, since exposure, conditions, and device options change rapidly in modern healthcare environments at present. B is wrong because a 3-year cycle still leaves dangerous gaps and does not match federal requirements. The OSHA standard demands annual minimums plus event-driven updates, which together ensure the plan tracks real conditions in the workplace closely. C is wrong because semi-annual review is more frequent than required, but the rule sets only an annual minimum. While more reviews are not prohibited, calling 6-month review the federal mandate misstates the actual standard the administrator must follow daily. The OSHA Bloodborne Pathogens standard sets a specific cadence for reviewing the exposure control plan, and understanding both halves of that rule is essential for keeping workers safe and staying compliant. The rule has 2 distinct parts. First, the plan must be reviewed at least once per year. Second, any change in work conditions, new safer devices, new procedures, new infectious agents, or shifts in patient population triggers an additional review regardless of when the last annual review occurred. The review process draws on 4 key inputs: the year's exposure incident reports, newly available safer device options in each category, feedback from frontline workers on device performance, and any regulatory updates from OSHA or the CDC. The plan is then revised, signed and dated before replacing the prior version. The Needle Stick Safety and Prevention Act of 2000 reinforced the bloodborne pathogen standard by requiring employers to actively evaluate safer sharps devices and document that process. Because safer devices reach the market every year, a static plan written once quickly becomes obsolete, which is exactly why the event-driven update rule exists alongside the annual minimum. A plan reviewed only once and never updated again fails the standard. The right answer always pairs the annual minimum with event-driven updates whenever work conditions change. Because either half alone leaves a gap in worker protection. Question 45. A laboratory tracks proficiency testing results across the year and reviews the threshold for acceptable performance to maintain accreditation. The standard pass rate that PT providers and CMS surveyors apply is well documented. Which of the following thresholds matches the standard PT acceptance rate for non-waived analytes? Your options are A. 80% acceptance rate, B. 50% acceptance rate, C. 30% acceptance rate, D. 100% acceptance rate. Pick one. Trust your gut. Here's your chance to test yourself. The correct answer is A. 80% acceptance rate. A is correct because the standard PT acceptance threshold is 80%. Laboratories scoring below that on any analyte across 2 of 3 consecutive testing events face unsuccessful PT performance and corrective action requirements. B is wrong because 50% acceptance is too lenient and would not protect against systematic analytical errors. The standard tightens to 80% specifically to ensure adequate analytical performance across testing events. C is wrong because 30% acceptance is essentially failing performance and would not satisfy CLIA requirements. The standard sits much higher at 80%, which laboratories must achieve consistently. The standard reflects current practice in routine clinical phlebotomy. D is wrong because 100% acceptance is unrealistic given normal analytical variation. The 80% threshold acknowledges variability while maintaining quality, and 100% would not be achievable in practice. Proficiency testing is the federal mechanism that verifies a laboratory consistently produces accurate results. The standard acceptance threshold every non-waived laboratory must meet is 80%, a number set deliberately by CLIA as a balance between analytical reality and patient safety. Each testing event, a laboratory's score for an analyte is the percentage of submitted values that fall within the allowable range. 80% or higher passes. Falling below 80% on the same analyte in 2 of 3 consecutive events earns the unsuccessful performance designation, triggering mandatory corrective action and possible suspension of testing. Exam writers offer near-miss values to test whether you have memorized the correct number. 30% is essentially failing performance. 50% would not catch systematic errors. 100% ignores normal analytical variation across instruments, reagent lots, and operators. 80% is the federally mandated balance point. 3 times per year, an approved PT program ships blinded specimens to enrolled laboratories. The lab runs each specimen and submits its values. The program grades each result as inside or outside the allowable range, then calculates the percentage passing. That percentage is what gets compared against the 80% threshold. Whenever a question asks for the standard proficiency testing acceptance threshold, the answer is 80%. Tighter internal lab goals and CLSI analytical specifications are different frameworks. 80% is the CLIR number, applied uniformly by CAP and all other approved PT programs. Question 46. A phlebotomy technician is approached in the hallway by a co-worker from radiology who is not assigned to a mutual neighbor's care and asks whether the neighbor tested positive for HIV during last night's admission. Which of the following actions should the technician take? Your options are A. Whisper the answer quietly. B. Look up the result first. C. Confirm only that admission occurred. D. Decline and explain HIPAA restrictions. Which would you go with? Lock it in before the reveal. The correct answer is D. Decline and explain HIPAA restrictions. D is correct because HIPAA and the NHA Code of Ethics both prohibit disclosure of patient information to anyone not involved in that patient's care. The phlebotomist must refuse politely and explain why disclosure cannot happen here. A is wrong because whispering the result still discloses protected health information to a co-worker without a treatment relationship. Volume does not change the legal status of the disclosure, and HIPAA penalties apply regardless of how quietly the words are spoken. B is wrong because looking up the result for someone outside the care team would itself violate HIPAA, since access must follow the minimum necessary standard. Curiosity-driven access is sanctionable separately from any subsequent verbal disclosure to co-workers. C is wrong because confirming admission still reveals protected information about whether the neighbor is in the facility at all. Even acknowledging presence may breach HIPAA when the inquirer has no clinical role with that patient encounter. HIPAA doesn't just restrict what strangers can access. It also governs what you can share with fellow employees. The key question is never where someone works, but whether they have a legitimate clinical relationship with that specific patient. The privacy rule limits access to protected health information to 3 categories: treatment, payment, and operations, and only when they involve the specific patient in question. Curiosity, social connection, or shared workplace do not qualify. A radiology co-worker with no care role for your neighbor has no authorized access, full stop. The correct response moves through 3 steps. Acknowledge the inquiry without giving any information. State clearly that HIPAA prohibits sharing the result, and offer to help the co-worker understand the rule if needed. The conversation ends there. No disclosure occurs. Even softer responses constitute disclosure. Whispering the result still discloses protected information regardless of volume. Looking up the result first violates minimum necessary access before any words are spoken. Even confirming admission reveals the neighbor is in the facility, and that alone is protected when the inquirer has no clinical role. When a co-worker lacks a treatment, payment, or operations relationship with that patient, the answer is always a firm, respectful decline. The line isn't about who works in the building, it's about who has a clinical reason to know. Question 47. A phlebotomy technician must decide which side of the needle bevel faces up during insertion. Which bevel orientation is the recommended standard in routine clinical practice, at the bedside, in routine clinical phlebotomy practice for the routine adult outpatient draw? Your options are A. Bevel down, B. Bevel up, C. Bevel to the side, D. Bevel rotation during insertion. Don't overthink it. Which one feels right? The correct answer is B. Bevel up. B is correct because the bevel up orientation reduces tissue trauma by presenting the sharpest part of the needle first. The orientation also makes a smaller wound in the vessel wall and improves first stick success. A is wrong because bevel down orientation presents the blunt edge of the needle first, increasing tissue trauma and reducing success. The standard rules out bevel down because it does not match design intent. C is wrong because bevel to the side orientation does not match standard practice of bevel up insertion. Lateral orientation does not optimize trauma reduction or vessel entry, so the standard places the bevel up. D is wrong because rotating the bevel during insertion is not the standard technique and creates unnecessary tissue motion. The needle is inserted with the bevel up and held steady through entry. The standard orientation for venipuncture is bevel up, atsam, and understanding why helps you apply the technique correctly every time. It comes down to needle geometry, tissue mechanics, and deliberate setup. The bevel is the angled cutting surface ground into the needle tip. When oriented upward, it presents the sharpest edge to the skin first, slicing cleanly through tissue rather than pushing through it. Any orientation other than bevel up compromises the needle's design. Bevel down presents a blunt edge requiring more force. Bevel to the side tears tissue laterally. Rotating during insertion adds microtrauma with every movement. Only bevel up enters along the needle's intended design. At the chair, the phlebotomist anchors the skin below the chosen vein with the non-dominant thumb. Enters bevel up at 15 to 30 degrees depending on vein depth, and drops the angle once a flash of blood confirms vein entry. The bevel orientation does not change during the draw, even when tubes are exchanged. Bevel up is the constant, held steady from entry through completion for minimal trauma and maximum first stick success. Question 48. A phlebotomy technician drawing a chemistry panel uses a small needle on a high vacuum tube, which produces visible foam. The chemistry result shows markedly elevated potassium and lactate dehydrogenase. The technician recalls the Shear's mnemonic for hemolysis causes. Which of the following causes matches? Your options are A. Small needle on high vacuum tube. B. Hematoma underlying the site. C. Reflux from underfilled tube. D. Excessive shaking during transport. Got a guess? Lock it in. The correct answer is A. Small needle on high vacuum tube. A is correct because the small needle on a high vacuum tube creates turbulent flow that lyses red cells, releasing intracellular potassium and lactate dehydrogenase. The mismatch between needle bore and tube vacuum causes hemolysis. B is wrong because a hematoma underlying the site is a separate hemolysis cause involving extravascular blood near the vein. The scenario describes turbulent flow from a small bore needle, not hematoma-related lysis. C is wrong because reflux from an underfilled additive tube causes hemolysis when blood flows backward into the patient. The scenario describes turbulent forward flow from a small needle, not reflux events. D is wrong because excessive shaking during transport hemolyzes specimens through mechanical agitation, not draw turbulence. The scenario describes the collection moment with a small needle on high vacuum tube. The standard reflects current practice in routine clinical phlebotomy. When a small bore needle is paired with a standard high vacuum evacuated tube, the result is turbulent blood flow, B, a classic pre-analytical error that damages red cells before the sample ever reaches the analyzer. The high vacuum draws blood faster than the narrow lumen can deliver it smoothly. Turbulence shears red cell membranes against the inner needle wall, rupturing them and releasing hemoglobin into the plasma, turning the specimen visibly pink or red. The specific analyte changes trace directly to cell composition. Potassium sits at roughly 25 times the plasma concentration inside red cells, and lactate dehydrogenase at hundreds of times. When cells rupture, those intracellular contents mix with the plasma and falsely elevate the reported values. The Shear's mnemonic covers all 6 contributing causes of hemolysis. Shaking causes mechanical agitation. Hematomas involve extravascular blood. Excessive force causes pressure damage. Aged specimens hemolyze through cell senescence. Reflux occurs with underfilled additive tubes. The small needle and high vacuum pairing is unique to equipment mismatch at the draw. The prevention is straightforward. Match your needle gauge to tube vacuum. A 23 or 25 gauge butterfly should pair with a low vacuum pediatric tube. When the stem describes foam in tubing, pink plasma, and elevated potassium or LDH, the cause is turbulent flow from equipment mismatch. Question 49. A phlebotomy technician is preparing for entry to an isolation room and reviewing the donning sequence under CDC guidance. Which of the following sequences describes the proper order for putting on personal protective equipment before patient contact in routine clinical practice and routine clinical phlebotomy practice? Your options are A. Gloves, gown, mask, goggles. B. Gown, mask, goggles, gloves. C. Mask, goggles, gown, gloves. D. Goggles, gloves, gown, mask. Which one is it? Pause the video if you need more time. The correct answer is B. Gown, mask, goggles, gloves. B is correct because the CDC donning sequence places gown first, mask or respirator second, goggles or face shield third, and gloves last, with the cuff extending over the gown sleeve. The order ensures full coverage before patient contact begins. A is wrong because donning gloves first traps the gown sleeve under the cuff and can compromise barrier integrity when the gown is later applied. The recommended order keeps gloves last, so they overlap and seal the gown sleeve at the wrist. C is wrong because starting with mask and goggles before the gown forces awkward gown application around face protection already in place. The recommended order applies the gown first while the worker can still freely manipulate clothing. D is wrong because goggles first create similar problems and leads to gown application around equipment already on the face. The standard order keeps face protection placement after the gown, so each step adds without disturbing previously donned items. Before entering an isolation room, the CDC specifies an exact order for putting on personal protective equipment. This sequence isn't arbitrary. It's designed to build a continuous, unbroken barrier across the body without disturbing pieces that are already in place. Donning follows gown, mask, goggles, then gloves, with the glove cuffs extending over the gown sleeve to seal the wrist. Doffing reverses the rationale. Gloves come off first because they are the most contaminated, and the mask comes off last because the face is most vulnerable to contamination during removal. The reason gloves go on last is structural. The cuff must overlap the gown sleeve at the wrist, creating one sealed surface with no gap. If gloves were donned first, the gown sleeve would trap beneath the cuff, breaking that seal and leaving skin exposed. When a test stem asks for the standard donning sequence, the answer is always gown first, mask second, goggles third, and gloves last. Each step layers cleanly onto the last, and doffing reverses the rationale to protect the worker during removal. Question 50. A processing technician is assembling a triple packaging system for shipping a Category B diagnostic specimen. IATA packing instructions 650 uses 3 layers, including absorbent material capable of containing the entire liquid contents in case of breakage. Which of the following layer combinations matches the system? Your options are A. Single bag with absorbent only. B. 2 layers, primary and outer. C. Primary, secondary, leak-proof, rigid outer. D. 4 layers, including dry ice always. Take a second. Which answer would you pick? The correct answer is C. Primary, secondary, leak-proof, rigid outer. C is correct because the triple packaging system places the primary tube with absorbent material first, a leak-proof secondary container second, and a rigid outer packaging third. The outer carries the UN 3373 diamond label and shipper information. A is wrong because a single bag with absorbent fails to meet the 3-layer requirement of IATA Packing Instruction 650. Category B substances require 3 distinct layers for safe transport. B is wrong because 2 layers fall short of the 3-layer requirement under IATA rules. The standard explicitly requires primary, secondary, and outer layers, not a simplified 2-layer system. The standard reflects current practice in routine clinical phlebotomy. D is wrong because 4 layers including dry ice always overstates the requirement. Dry ice is added only when the specimen needs frozen transport, while the 3-layer rule applies regardless of refrigerant. We don't have a theory section for this question. Refer to the explanation above for the underlying concept.
You have reached the end of our study video for the free complete exam preparation. Visit our website link in the description, and you can find thousands of practice questions and comprehensive study guides on our website. Thank you for studying with us today. See you in the next video.